Good evening, dear students. There was some technical issue with the projection. So I just want you to tell me whether the audio and video is fine so that we can continue. Good evening, dear students. There was some. Okay, so we are looking at this question, which is asking us about which of the following is going to be the earliest identifiable cell population when we are talking about epiblast cells in the region of primitive streak. So what about this primitive streak, and what about this earliest identifiable cell? Let us look at one of the diagram here, which we are drawing. If you're looking at the blastocyst at week number 2, you'll find that the transverse section of blastocyst will have two type of cells. There'll be a dorsal cell, which is called as epiblast, and there is a ventral cell, which is called as hypoblast. There are two cavities also, and as you talk about the cavities, there will be one dorsal amniotic cavity, ventral is yolk sac cavity. Now, by the end of week number 2, that is day number 14, and you'll find that the epiblast cells are proliferating. And these epiblast cells, as they are proliferating, they'll be forming what is called as the primitive streak. So here we are now looking at the primitive streak. Primitive streak is formed by the epiblast cell proliferation, and that will happen at the end of the 14th day. We have isolated some cells from here, and they are called as primordial germ cells as early as day number 14. Now, that means the very first derivative from the epiblast cells is basically going to be the primordial germ cells. Primordial germ cells are migratory cells. They'll be arising from the epiblast cells, the very first derivative we have found, and then they'll be moving towards the genital ridge to form gametes. If there is aberrant migration of these primordial germ cells, then we'll find that there can be germ cell tumors like teratomas. After some time, you will notice that this epiblast cells, which are in the primitive streak, they are migrating downward towards the yolk sac. They will replace the hypoblast, take their place, and form the first germ layer, which is called as endoderm. So when will that happen? This is now going to be the week number 3, which is, you should call it as embryo now. And as you look at the embryo, week number 3, you find that a germ layer has formed, which is at the roof of yolk sac, and that is the first germ layer to form the endoderm. So let me repeat the information. If you're looking at the week number 2 blastocyst, that is by the end of the week number 2, that is day number 14, you find that the epiblast cells were proliferating, and as they are proliferating, they'll form primitive streak. And from this primitive streak, we have isolated primordial germ cells, and these primordial germ cells, they were migratory cells. They have to migrate to the genital ridge to form gamete, and the process is called gametogenesis. So the very first cell which we derive from the epiblast in the primitive streak is actually primordial germ cell. What is the second thing? These epiblast cells, they migrate downward, they replace the hypoblast cell, take their place, and they will form the first germ layer, which is endoderm. They continue going down, and they'll form one more layer, which is the mesoderm. And lastly, the epiblast cells, which never migrate, they were at the floor of amniotic cavity. Those epiblast cells will then change into the ectoderm, which is the last germ layer to form. So last germ layer to form will be the ectoderm, which will be at the floor of amniotic cavity. So the point is that it is the epiblast which is going to form number 1, primordial germ cell, number 2, endoderm, number 3, mesoderm, number 4, ectoderm in a sequence. But which was the earliest to find? That is the question. You can look at the question again and you know your answer. The question is asking that which of the following is the earliest identifiable cell population derived from epiblast cells in the region of primitive streak, and your answer should be primordial germ cell as early as by the end of day number 14. That is what we have to tell. And if you are talking about the endoderm, it will be forming in the week number 3. So first is going to be endoderm, second is mesoderm, lastly you'll have ectoderm. But the very first cell which you got is primordial germ cell. That is what we have to mention. I just wanted to know whether the audio and video is all fine and you are able to see and discuss things clearly. Okay, so as we continue, we are looking at the next question. It is one of the question which is asking us about the derivatives of neural crest cells and the exception. As you'll find in this choices, there are ciliary cells, ciliary muscle, retinal, pigment epithelium, ciliary, ganglion, melanocytes. We are talking about the developing eyeball here. And if we are talking about the developing eyeball, you have to remember that in the eyeball, we'll find that there are some derivation from neural plate ectoderm. Number one, it is neural plate ectoderm. Number two, we'll see that there are some derivative of the surface ectoderm. And number three, you know that it will have some mesoderm also. But you have to understand mesoderm is two type, primary and secondary. And since this is eyeball in this region, anterolateral area, mostly this mesoderm is from neural crest cell, which is secondary mesoderm. So most of the eyeball actually come from secondary mesoderm, which itself is coming from neural crest cell. Now, if we are focusing upon developing eyeball, there will be 5 derivative of neural plate ectoderm, which we have to remember, 2 derivative of surface ectoderm. Otherwise, everything else will come from neural crest cells, either from neural crest cells or from neural crest cell derived secondary mesoderm. That is what we have to understand. So I have got a diagram which we'll be drawing, but you need to understand that the optic nerve, number one, is coming from neural plate ectoderm. Number two, the 2 layers of retina, they also come from neural plate ectoderm. Number three, the epithelium on ciliary body. Number four, the epithelium on iris. And number five, the epithelium, the muscles of the iris, which is sphincter pupillae, dilator pupillae, they all come from neural plate ectoderm. We'll draw a diagram, discuss 5 derivative of neural plate ectoderm. When it comes to surface ectoderm, it will form the eye lens and the surface epithelium of cornea. So first layer of cornea, that will be along with eye lens coming from surface ectoderm. Otherwise, rest of all the things in the eyeball are from neural crest cell. So what that could be? That could be connective tissue of iris, connective tissue of ciliary body, or maybe connective tissue of the sclera, the uvea, the vitreous. So let us draw the diagram and discuss the derivatives again. Let us first look at the 5 derivative of neural plate ectoderm, which are contributing to the developing eyeball. So what are they? You will see that the very first thing is the optic nerve. So very first thing is optic nerve, and optic nerve number one is coming from neural plate ectoderm. We want to discuss what are the 5 derivatives of neural plate ectoderm. Number one, optic nerve. Number two, you'll find the 2 layers of retina. So number two, it is the retina. Retina has 2 layers, the pigment epithelium as well as neural layer. That is also coming from neural plate ectoderm. Number three, you'll find the epithelium on the ciliary body. So number three is epithelium on the ciliary body. That is also from neural plate ectoderm. Number four, it is the epithelium on the iris. So epithelium on the iris is also from the neural plate ectoderm. Number five, you'll find there are 2 muscles in the iris, basically, and these muscles, the iris muscles, which you know the names will be sphincter pupillae and the dilator pupillae. These muscles are also from neural plate ectoderm. So what are the 5 derivative of neural plate ectoderm? Yes, Indu, Captain YSR, educate me, Dr. Sampad, Dr. Philadelphia, Prajwal. Welcome to the session. Somehow now I have got the feed from the app, means the chat. So as you are looking at the 5 derivative of the neural plate ectoderm, what are they? Number one, it is the optic nerve. Number two, it is the layers of retina, which is neural layer and the pigment epithelium. Number three, it is the epithelium of ciliary body. And number four, it is the epithelium of the iris. And number five, it is the 2 muscles of iris, which you know are called as sphincter pupillae, dilator pupillae. Then what are the two derivative of surface ectoderm? The two derivative of surface ectoderm can be shown as eye lens. Number one, it is the eye lens, and number two, it is the first layer of cornea. So cornea, it will be having 5 layers, but the cornea, the first layer, is coming from surface ectoderm. So what are the two derivative of surface ectoderm in the eyeball? Number one, we are mentioning that it is the eye lens. And number two, first layer of cornea. It is the very first layer of cornea that is from the surface ectoderm. So now 5 derivative of neural plate ectoderm and 2 derivative of surface ectoderm, rest all in the eyeball is from neural crest cell. So if rest all is from neural crest cell, can you tell that what all are coming from neural crest cell? Let us discuss. The 4 layers of cornea, the 4 layers of cornea, they will be coming from neural crest cell. Then what else? You will see the connective tissue of the iris is from neural crest cell. The connective tissue of the ciliary body is from neural crest cell. The choroid is from neural crest cell. The sclera is from neural crest cell. The vitreous is from neural crest cell chiefly. So can you tell me some derivative of neural crest cell? Instead of telling what are the derivative of neural crest cell, you should tell everything in the eyeball is from neural crest cell, or neural crest cell derives secondary mesoderm, except for 7 things which came from ectoderm. So if you know the 7 things which came from ectoderm, rest everything should come from neural crest cell. So what are the 7 things I have to remember which came from ectoderm? 2 from surface ectoderm and 5 from neural plate ectoderm. So what are the 2 derivative of surface ectoderm? That is eye lens and first layer of cornea. And what are the 5 derivative of neural plate ectoderm? The 5 derivative of neural plate ectoderm are the optic nerve, retina, 2 layers, the epithelium of ciliary body, epithelium of iris, and 2 muscles of iris. They are from neural plate ectoderm. So that gives you an idea what should be your answer. You already would have marked your answer. It is retinal pigment epithelium, because retina has 2 layers. Maybe it is the neural layer, or maybe it is the pigment layer. They are all coming from neural plate ectoderm. Actually, neural plate ectoderm will be giving us 5 derivative, and the 5 derivative, one of the derivative is the 2 layers of retina. If you talk about ciliary muscle come from secondary mesenchyme, and that secondary mesenchyme was given by neural crest cell. If you talk about ganglia, all the ganglia in our body, most of the ganglia, they are coming from neural crest cell. If you're talking about melanocytes may be in the iris, or melanocytes may be in the skin epithelium, or some of the tissues in the brain. They are all coming from neural crest cell. Neural crest cell will form melanoblast, and that melanoblast will form the melanocytes, and the color of the iris which you are having is because of that, and that is all from neural crest cell. So everything is from neural crest cell except choice number B. We will keep that answer. Now, yes, Maurya, good evening. Now, look at the next question. It is asking, what is the mechanism by which the cell in the arrow marked structure is going to influence the nearby cells? So what are we looking at? Can you tell me? I'm asking you, can you write in the chat which slide are we looking at? I can see that there is a blood vessel here. I can see these are serous acini. These are all serous acini. And what I can see is bunch of cells, and bunch of cells. So what do you think this is? This is islet of Langerhans, and these islet of Langerhans and these acini are basically belonging to pancreas. So we are looking at a slide of pancreas. Now, if it is a slide of pancreas, these serous acini will be giving pancreatic enzymes. They'll be giving pancreatic enzymes, and islet of Langerhans will be giving like alpha, beta, delta, gamma cells are there. They will be giving glucagon, or they are giving the insulin, or they are giving the delta cells will be giving the somatostatin. The alpha cells, as they are giving glucagon, can be inhibited by secretions of the beta cell insulin. That is called paracrine effect. So as we are mentioning, the question asking is about paracrine effect. So for example, delta cell giving somatostatin can reduce the secretion of alpha beta cell, glucagon and insulin, all that. So we are talking about paracrine. What about the other? Say neurocrine. Neurocrine is basically the nerve impulses, and we don't have these neuron bodies here, so will not apply here. And yes, Grace, islet of Langerhans. Endocrine, you can say, because these cells, they will put their secretions into the blood vessels, and they can have effect on this, but that'll be indirect. They are asking influence the nearby cells, so it must be paracrine. And epithelial to mesenchyme, that is something you can see in the process of gastrulation. I have a table. Let us go look at the table. So when we are talking about some of the methods, autocrine is something which one cell can affect the same cell again by its secretions. Say, for example, the T lymphocyte giving IL-2, and it can affect itself only. That is called as autocrine. If you are asking about this question, it was paracrine, because it is going to affect the nearby cells, as I told, like somatostatin given by delta cell. They can affect the alpha beta cell and decrease their secretion of glucagon and insulin. Even the beta cell, when it was giving insulin, can affect the alpha cell, reducing their glucagon secretion. So our answer is paracrine. What about endocrine? Endocrine means you are having hormones going to blood vessel and then systemic circulation and then affecting other glands. It can come back to the again pancreas, but that will be a long method, and question is asking for nearby cells. So insulin working on the muscle cells and coming back again to islet of Langerhans, it is a possibility, but that is not what the question is asking. And neurocrine, actually these cells are not neuron cells, like using acetylcholine at the neuromuscular junction, all that is not the question. What about this epithelial to mesenchyme transformation? That is one choice, which is talking about, say, when we were telling about gastrulation. Gastrulation is the formation of 3 germ layers from the epiblast. In that process, you see that epithelial cells, they turn into mesenchymal cells, like they are forming mesoderm also. But that is not fitting well in what the question is asking. Question is asking, what is the mechanism? As you can see, what is the mechanism by which the cells in the arrow marked region, that is islet of Langerhans, is going to impact the nearby cells? None other than the paracrine. That is our answer. So choice B should remain as our answer. Looking at the next question, desmosomes are present in which part of the cell? Now you have to be careful. Though there are some of the authors, they use some terms which are, it is always, you should follow convention. You should always give your answer from the books. So which is the best book for such a scenario? It is Gray's Anatomy. You look at Gray's Anatomy and you'll get your answer. You're asking about desmosomes. Desmosomes are cell junctions, and these cell junctions, they are holding cells with each other. So where should be they? Are they apical? Are they basal? Apicolateral is not a exact term. It can always describe the details. Basolateral is a better term, actually. So you have to use the terminology which is used at books, and should not derive your own terminology. So what do you think is the answer? You see, this is a diagram from Gray's Anatomy, and according to Gray's Anatomy, there are 2 domains. There is one apical domain which they are showing from here to here. This is the apical domain, and then there is another one which you can see is the basolateral domain. And in the basolateral domain, you'll have to include almost every other cell junction except for one, which is apical. So which is the apical? Apical is the tight junction, which is also called as occluding junction. So if a question comes, what is the location of tight junction or occluding junction? You should answer it as apical domain. Otherwise, if a question is like, if we get a question on zona adherens or macula adherens, which is desmosome, other name of desmosome is the macula adherens, or if you're getting a question even on hemidesmosome, what should you answer? May it be this hemidesmosome which attaches cell to the basement membrane. May it be the macula adherens, which is the other name of desmosome. May it be the zona adherens. Your answer should remain basolateral. Basolateral. Let me show this information again in a table. The point is, only for the tight junction, you should say it is the apical answer, which is a barrier. Like you don't want some unwanted substances from the lumen or surface towards the intercellular space. That is the purpose of tight junction, preventing that kind of movement. So it is kind of a barrier, blood-brain barrier, blood-testis barrier, blood-thymus barrier. That is where you need these tight junctions. If you're talking about zona adherens, maybe zona adherens, maybe desmosome, or maybe it is the gap junction. You see, all of them. You can see here, when we are talking about maybe zona adherence or desmosome or gap junction, you should keep answering it as basolateral as per Gray's anatomy. There are other terms also, like you have seen apicolateral. What is apicolateral? Is there apicolateral mentioned in any book? No. So you should not use such terms which are not conventionally used in the by the authors. And only if they were asking about tight junction, then you should say it is apical. There are only two things. I have shown you there are only two things. Either it is apical domain or it is going to be the basolateral domain. There is no other domain. If you are talking about apical, you have to understand tight junctions are apical. And if you're talking about others, maybe the zona adherence, maybe macula adherence, which is the other name of desmosome, or maybe hemidesmosome, you should keep answering. For zona adherence or macula adherence desmosome or for hemidesmosome, you should keep answering it as basolateral, because this region is what we are calling as basolateral. So I hope you got the point, and your answer to this question is choice number D. See, you have to be careful when you are talking about this NEET PG exam or INICT exam. These questions, they repeat themselves. If the questions don't repeat, the topic will repeat. So your job is, like I say, there's a dictum. Dictum is you should know everything about few topics. You should know everything about few topics, and this is one of the topic, which is cell junction. So you should know everything about the cell junction, because anytime a question will come and it will not be a simple question, and you should be able to answer it because it is a repeat topic. And then you should know few things about every topic. So few things about every topic, randomly you are reading, you are getting some information, but rank decider questions are here. Anything which is repeated, you should not make mistakes. So keep your answer as the basolateral. If you say apical, in the apical, you will find, yes, Dr. Priya, hi. So in the apical region, if you are looking at apical region, you should say, crystal medicos, what do you want to be repeated? Let me show the things again. See, first of all, you should look at this diagram. This is one of the cell which is attaching to other cell. So there'll be some cell junctions. These are cell junctions. These are cell junctions. This is one of the cell. This is another cell. And you want to talk about cell junctions. So where are they present? There are two things only. Either there's an apical domain where you'll have tight junctions, or there is a basolateral domain. So if it is basolateral domain, which cell junctions are we talking about? We are talking about zona adherence, the macula adherence, other name of desmosome, and then we are also talking about hemidesmosomes. They will be basolateral. Now, if you have this idea, you can look at this table also. Only for tight junction, you should say apical as the answer. Otherwise, whether you are talking about zona adherence or desmosome or gap junction, any of that, you should keep answering it as basolateral, basolateral, basolateral. And that is why in this question, we are keeping our answer as basolateral, because you are asking about desmosome. Desmosome is the other name for, the macula adherence. They are having several names. You can call them as macula adherence. You can tell spot welding. They hold cells with each other. So apical, you can say tight junction, no problem. But this is about desmosome, so you should keep your answer as basolateral. Now, going to the next question. Which of the following is involved in detecting the dynamic two-point discrimination? It is about dynamic two-point discrimination. What do you mean by dynamic, and what do you mean by static two-point discrimination? Now, you see here, you are checking for two-point discrimination. You are checking for two-point discrimination, and this is static. If you start moving these 2 points, asking the patient, can you feel the 2 points moving like that? Then you will say it is dynamic. So who is detecting the static 2-point discrimination, which is shown here? And if you start moving, then who is detecting the dynamic 2-point discrimination? For that, you have to understand, one is the Merkel receptor. Merkel receptor in the basal layer of epidermis. So basal layer of epidermis, you'll have Crystal Medicos is asking, why don't you take discussion on your studio? It gives too kuch energy or much energy. Dr. Priya is telling it is C. Are you sure, Dr. Priya? I'm see, Crystal Medicos, I'm taking this session from my studio only, but this setup is different. It is from my studio only. Energy, if you want, it is always good to stand and teach. That gives you more energy, I understand. But systems, they keep modifying and we have to adapt. So I'm adapting or trying to adapt. So if you are talking about static 2-point discrimination, means you are just touching the 2 points, then it is Merkel, which is for the basal layer of epidermis, present in the basal layer of epidermis. But if you are talking about dynamic 2-point discrimination, your answer will be Meissner. Your answer will be Meissner. So here the answer will be Meissner. Let me show you some of the diagrams now. You see, when we are talking about these receptors, we will focus upon 4 of them. Number 1, it is the Merkel cell. Number 2, it is the Meissner. Number 3, it is the Pacinian. And number 4, it is Ruffini. You will find that Merkel cell is present in the basal layer of the skin epithelium or epidermis. So as you can make out, this is the epidermis here, and below that is the dermis. So as we talk about number 1, Merkel cell is in the basal layer of the skin epidermis, and it is a slowly adapting receptor. Now, when you say it is a slowly adapting receptor, that is for the static 2-point discrimination. That is static 2-point discrimination. So if you look at the epidermis, at the basal layer, you have this Merkel cell, and Merkel cell is slowly adapting. It is for static 2-point discrimination. Now look at the second one. You are focusing upon Meissner corpuscle. Meissner corpuscle is here, dermoepidermal junction. It is at the junction of epidermis and dermis, and that is the Merkel cell. Merkel cell is for dynamic 2-point discrimination. So when you are talking about the Merkel cell, this Meissner corpuscle, it is for dynamic 2-point discrimination. That means you are moving the 2 points, and you're asking, can you feel the 2 points moving? That will be detected by the Meissner. If you are talking about the number 3, that is the Pacinian. Pacinian, you will find it is in the deep dermis. It is in the deep dermis, as you can see. Pacinian corpuscle has this onion skin kind of appearance, and it is present in the deep dermis. It is for pressure and vibration. P for P. Pacinian for pressure, and also it is for vibration. Vibration also something like 256 hertz of tuning fork. So you're touching the tuning fork. Tuning fork is 256 hertz. So that kind of vibration means high frequency vibration can be detected by Pacinian corpuscle. So Pacinian corpuscle is detecting the high frequency vibration. Who is detecting low frequency vibration? Low frequency vibration, like the flutter of the butterfly wing on your skin. Flutter of the butterfly wings on your skin, that is low frequency vibration. And Dr. Priya, FMG questions, this is NEET PG, it is a bit deeper. So for FMG, questions are at a slightly lower level, means they are not so difficult. But these pattern, the question which you are looking at are basically for NEET PG, they are at a higher level. So just for your information, FMG, it will not go so deep. Though recently I've seen that they are definitely going deeper, but then maybe some 10% questions. So don't bother. 90% questions are simple questions. They are not of this standard. This standard is when you have 2 lakh students sitting, and there are only 25,000 seats available. So out of say 10 students, only 2 or 3 will get the seats. So that is then the stand goes high. So these are some high standard questions, and frequently asked in the exams. So when we are talking about the low frequency vibration, that will be the Meissner corpuscle. So Meissner corpuscle is for low frequency vibration. Like I told, flutter of the butterfly wing on your skin, that is around say 50 hertz. In the range of 50 hertz, that will be the Meissner. What about the number 4, Ruffini? As you are talking about Ruffini, you will see that Ruffini is slowly adapting again, and like the Merkel, and it is for detecting, say, dermal stretch. So it can detect the dermal stretch. It can also detect the capsule stretch. giving you the sense of proprioception, joint capsule proprioception. So if you talk about Ruffini receptor, it is in the deep dermis and it is slowly adapting, and it is for dermal stretch. It is also taking stretch from the capsule, like for proprioception. So in that sense, if you are looking at this question, which is asking that which of the following involved in detecting the dynamic 2-point discrimination. If you said dynamic, then it is Meissner. Meissner corpuscle is not only for dynamic 2-point discrimination, it is also for low frequency vibration. Say for example 50 hertz. If you are talking about the Merkel disc, it is for static 2-point discrimination. Static 2-point discrimination. If you're talking about Pacinian corpuscle, P for P, so P for P means pressure and also vibration. That vibration is, say for example, in the range of 256 hertz. That could be your phone vibrating. So your phone vibrating, or it could be the tuning fork. So that kind of high frequency vibration can be detected by the Pacinian corpuscle. If you're talking about Ruffini receptor, it is detecting stretch, and that stretch could be from the skin, dermal stretch, or that could be from the joint capsule. It is working for giving you the sense of proprioception. So I have given you some details, but again I'll tell you, these topics, they are repeat topics, and you should know everything about few topics, and that is what I have chosen. Now, as you go on to the next question, choose the correct option regarding the skin structure. And you are seeing epidermis can regenerate from the hair bulb and sebaceous gland. See, this is not normal thing, but it can happen if there is some pathology like burns. If there was burns patient, you'll find that the hair bulb, there are stem cells. In the sebaceous gland, there are stem cells, and they can definitely give you the regeneration of epidermis. Normally, it doesn't happen, but it can happen in pathological situations. So I have to accept that it is true. Now, if number one is true, then what about number two? Stratum corneum is the outermost layer of the skin, yes, but it is not cellular. It doesn't have cells. I'll show you a diagram. It is acellular. So this is false. What about epidermis ectodermal? Of course, the surface ectoderm form skin epithelium, that is epidermis, no problem. What about the dermis and hypodermis? They are under the skin, they are from mesoderm. So they'll be from mesoderm. Definitely they are not from endoderm. Endoderm forms tubes like gut tube, and gut tube giving respiratory tube, or you can say lower part of genitourinary tube. So lower genitourinary tube, these are the things. Their epithelium is from endoderm, and epithelium form glands, so even their glands are from endoderm. If you are talking about the dermis or hypodermis, it is mesodermal, because if you focus upon endoderm, endoderm gives you some of the epithelium of the gut tube, respiratory tube, lower part of genitourinary tube, and not only they'll give epithelium of these tubes, but also the glands. So what is the other detail? You see, skin epithelium, when you talk about, some of the epithelium goes along with the hair follicle also. And when the epithelium is going with the hair follicle also, which you can see here, the stem cells are present even in the hair follicles. Stem cells are also present in this sebaceous gland, which you are seeing nearby. So even the sebaceous gland will have some of the stem cells, even the hair follicles, they'll be having stem cells, and if required, they can always regenerate the epithelium. Especially I told you, like case of a burns patient. So that is one thing. Second thing is, we are telling that the topmost layer, which is stratum corneum, is cellular. No, it is not cellular. The cells, they have lost their nuclei organelles, and they have, let me show you a diagram here. See, stratum corneum is here. This is the stratum corneum. And if you look at the stratum corneum, you'll find that there are cells, but they are broken. They don't have any nucleus. They don't have any organelles. They are acellular, basically. Means the cells have been lost. So stratum corneum do not have any cellular component, and you cannot call it, it is the topmost layer, of course, but it is not having any cells. Cells are present, of course, in the lower layers like stratum granulosum. You can say stratum granulosum will have, and of course then you can see the cells are available. That could be stratum spinosum or stratum basal. In the stratum basal, you were talking about this Merkel cell also. So Merkel cell, which is for static 2-point discrimination. Again, I'll tell you, this is one of the topic which is repeat topic and continuously asked. You should know everything about few topics, and this is one more. I have taken only those topics. So you have to keep your answer as the choice number 1 and 3, because only you want the correct option. So only choice number 1 and choice number 3, they are correct option. We understand this is wrong because it is acellular. We understand this is wrong because they are not endodermal, that is mesodermal. So only possible answer is choice number A. Now, as you're moving further, identify the arrow marked structure. Immediately you'll see lung alveoli. So these are the lung alveoli, you can see, but then the arrow mark is here. And if that is the arrow mark, you are looking at some channel where the air was passing and air will be passing further like this. So what exactly is this? You should have some basics here. Again, a topic which is highly repeat topic. You have to understand that when we are coming from the trachea to the bronchus, there'll be a conducting pathway. And when you come into the respiratory pathway, in the respiratory pathway, you'll have the respiratory bronchiole. So beyond this is respiratory pathway. Why would you say that beyond this is respiratory pathway, starting with respiratory bronchiole, moving on to alveolar duct, and then into alveolar sac, into alveoli? Yes, Dr. Ambika, you are correct. That is terminal bronchiole they have marked. So respiratory bronchiole is respiratory unit because you see there is an opening of alveoli. So wherever the alveoli are opening, that is where you will find respiratory gas exchange has begun, and it begins with the respiratory bronchiole. You do not see any opening of alveoli even in the terminal bronchiole. So terminal bronchiole don't have alveoli opening. You should know the epithelium of trachea and bronchus will be stratified squamous epithelium with the pseudostratified ciliated columnar epithelium with goblet cells. But these goblet cell number keep decreasing. The cilia keeps decreasing. We also have this hyaline cartilage, but that hyaline cartilage also keep decreasing. In fact, the hyaline cartilage and the goblet cells, they are present only till the bronchus level, not at the bronchiole level. So only till bronchus level, you'll have this goblet cell and the hyaline cartilage, not beyond that. That means if you're talking about bronchiole, like terminal bronchiole, or you are talking about respiratory bronchiole, they should not have any of the hyaline cartilage or goblet cell. They may have some cilia, but they should not have any hyaline cartilage or goblet cell. Look at the epithelium. Epithelium also changes. It was tall, but it is becoming shorter now. So what is the epithelium in the terminal bronchiole? It is columnar, ciliated columnar becoming cuboidal and losing the cilia also, because cilia you have to lose. So terminal bronchiole is columnar becoming cuboidal with cilia and losing the cilia. What about respiratory bronchiole? Respiratory bronchiole, you'll find it has become cuboidal. Maybe some cilia are there, but then you have to lose the cilia. I have a table. I'll show that in table also. Then what about the alveolar duct, alveolar sac, or alveoli? Of course, they will not have any of such things. They do not have any of such thing. They are losing all the cilia or goblet cell, no cartilage, nothing. They have smooth muscles, basically. Even smooth muscle will be lost finally. So this is the terminal bronchiole you are looking at. And remember, how do you identify terminal bronchiole? Terminal bronchiole, the epithelium is ciliated, columnar becoming ciliated, cuboidal. Cilia, they are losing. They don't have any goblet cell. They don't have any cartilage. There is replacement by smooth muscles. So smooth muscles are there. Like for bronchoconstriction, bronchodilation, you need smooth muscle. But you see, the wall is intact. There is no communication with the alveoli. There is no communication with the alveoli. So since there is no communication with the alveoli, respiratory gas exchange is not happening. It is conducting pathway. It is conducting pathway. It is not yet respiratory pathway. Respiratory pathway will begin with respiratory bronchiole. Now, why would you say respiratory pathway begin with respiratory bronchiole? Because you see now they are communicating with the alveoli. So once you see there is a break in the epithelium, and there is a communication with alveoli, means respiratory gas exchange has started. You are in the respiratory unit and respiratory bronchiole has started. So what is the other difference between these two? What is the difference between the terminal bronchiole and respiratory bronchiole? One, I told you, it is intact cell membrane, no communication with alveoli. Number two, you are seeing that respiratory bronchiole has broken up and it is communicating with alveoli. Number two, here you will find epithelium was ciliated and columnar becoming cuboidal. Here you will find it is ciliated cuboidal and losing cilia. So this may be columnar cuboidal, but here it is cuboidal. Then you can see that the terminal bronchiole continues as respiratory bronchiole, continues as alveolar duct, continues as alveolar sac. Alveolar sac, you can see a lot of alveoli are there. That is what you call alveolar sac. You see this table giving you all the details now. As you can start with the bronchus. In bronchus, what is the epithelium? Like trachea. It is pseudostratified ciliated columnar with the goblet cell. Then what about terminal bronchiole? I told you. In terminal bronchiole, it becomes columnar, becoming cuboidal, but there is no goblet cell, no cartilage. And what about respiratory? Respiratory, it is becoming shorter and shorter. The epithelium is becoming shorter. It has become simple cuboidal. Maybe some cilia are there, but there is interruption by alveoli. See, there is interruption by alveoli, but here there is no interruption in terminal bronchiole. What about alveolar sac? Alveolar sac, simple squamous epithelium. Alveoli are simple squamous, scattered. Type 2 pneumocytes are there, cuboidal, but mostly it is simple squamous. If you are now looking at the cartilage, cartilage is present only at the bronchus level. Absent, absent, absent whenever you are talking about respiratory unit or bronchiole level. What about the smooth muscles? Smooth muscles are increasing, but then in terminal bronchiole, you will have more defined. And if you are talking about this respiratory bronchiole, they reduce in number. Here you don't have any. Means smooth muscles, first they increase and then they reduce in number. What about the glands? Glands are present only trachea, bronchus or smaller bronchiole. Then they are absent everywhere. As the lumen goes down, you have to reduce the glands. Goblet cells are present in the trachea, bronchus, but not at the level of bronchioles. If you're talking about alveoli in the wall, no alveoli, no alveoli. This is only starting at the level of respiratory bronchiole that you are communicating with alveoli. And of course, if it is alveolar sac, you will have only alveoli. Function, you know, so you can just go through this table. You can pause the YouTube video. Now, Dr. Pia is asking, mention which questions from FMG side by side if you can. All these questions, they will come from they will come for FMG, but at a lower level, not at so depth. All these questions are repeat questions. They are being asked in INCT, in NEET PG, in FMGE. Only thing is the level of depth is more in INCT, still more deeper in NEET PG, and shallower in FMG. Topics are same. Yeah, so Educate Me is mentioning that there is no harm in listening. But you should know that if it is FMG, the level will be not so deep. Okay, and topics, if you're asking, they are the same topic. Every examiner is asking same topics. I take only those topics which are highly repeated topics. So as you can see, this was the diagram given to us, and this was the arrow mark where we had, and that is basically terminal bronchiole. Terminal bronchiole becoming respiratory bronchiole now here. So as you see, Crystal Medicos is telling it is a session for, is it a session for USMLE? Take it from me. USMLE, NEET PG, INSCT, FMGE, these examiners, they ask you same topic. And of course, it is working for USMLE only. My teaching is such that you can prepare for any exam. Only thing is USMLE will be more technical. It will be more knowledge based. It is not something like crude memory. You have to use your brain. And that is how USMLE people prepare questions. Otherwise, same topics. If you attend my class, you are preparing for a USMLE also. You are preparing for INSCT, you are preparing for NEET PG. But if you are preparing for FMG, you go a little bit shallower. My teaching is all in one. It works for any exam. It works for your university exam also. So till here, it will be the terminal bronchiole, but beyond this, it is the respiratory bronchiole. So that will give you an idea that in this question, what should be answered, because the arrow mark is here. You can see that is why we'll say it is terminal bronchiole. I told you that terminal bronchiole will have no communication with the alveoli. It is the respiratory bronchiole which will be having the communication with alveoli. So there'll be break in the wall. And if you see the break in the wall continuing with the alveoli, then you say this is respiratory bronchiole. So the point is, this is still terminal bronchiole, and these are the respiratory bronchioles. So keep your answer terminal bronchiole here, because the arrow mark, as you know, was here. Yeah. So now the next question. It is asking, which of the following cranial nerve is not associated with olfaction? Look at the kind of questions these examiners are asking. We will see olfaction means the cranial nerve number 1, which is coming from telencephalon. So cranial nerve number 1 is the only possible answer. But then look at the options. You don't even have this cranial nerve number 1 in the option. So what are we trying to say here? See, olfaction is something which is related to flavor, and some people can associate flavor not only with smell but also with taste. So anything which is related with taste is to be included here, and also some irritation, like say pungent ammonia you are talking about. The irritation can be directed by trigeminal nerve. So trigeminal nerve can also be taken because it is like a smell of ammonia. Smell of ammonia is different, but smell of ammonia can be also taken, the information can be taken by irritating nature of it. So what about taste? Taste is, FGV nerve. What is FGV nerve? Facial nerve, number 7. G is glossopharyngeal, 9, and vagus is 10. They carry taste sensation. So if you are talking about that olfaction, the only possible answer is olfactory nerve. But where is olfactory nerve? They have not given. And this is a repeat question. This is a repeat question. Remember, when you are preparing for your NEET PG, when you are preparing for your INI-CET, and even if you are preparing for your FMGE, you have to go through last 5-year questions. Yes, Dr. Ambika, you have answered it correctly. You have to go through the 5 years, increase it to 10 years, and increase it to 15 years, because now I'm seeing questions which were asked about 15 years back. They are coming again. This is one of the questions which came quite early in course of this entrance exam thing. A question which came 15 years back also are repeating themselves. So you have answered correctly, yes. Let me give the details now. You see, when we are talking about any flavor means you are talking about not only smell, but you are also talking about taste here. That is why you can take the cranial nerve number 1, of course, because that is for smell. You can always tell that, of course, it is about the smell, but not only about smell. It is about the taste also, FGV nerve. So when you say FGV nerve, facial, glossopharyngeal, and vagus, you have to include them. It is also about the touch, temperature, pain, etc. And that is where it is the trigeminal which is coming into picture. I told you, if there is a pungent smell, it is irritating, that is also going to tell you about flavor. So in that sense, any sensory nerve should be working with the smell for giving you the sense of flavor. That is what I can mention here. Otherwise, things are very deep. Now, as I see, Dr. Ambika, you have answered 12, but let me show you one statement now. Look at this statement. This statement is olfactory information is conveyed from olfactory bulb, the hypoglossal nucleus, via interpeduncular nucleus, and both fast dynamic dysynaptic polysynaptic pathway. What would you say now? Even cranial nerve number 12 is related with cranial number 1 for smell pathway. Now you will counter that, sir, cranial nerve number 12 is a pure motor nerve. If it is a pure motor nerve, then how can it carry sensation? Yeah, Grace is telling the thing which I also wondered. But the more I read, the less I know. The more I read, the less I know. Your perceptions, your knowledge will be challenged. And it is being challenged. So this is a journal which is mentioning that olfactory information from the olfactory bulb is related with the hypoglossal nucleus. But maybe you don't need that much of depth. And if you're telling, Grace, you are telling that it is a motor nerve, I'll accept it is a motor nerve. But actually, is it a pure motor nerve? That is a question. Don't bother much. Your answer is correct. Let us not beat our head around something which is, too much in depth. So let us just keep our answer as 12th and proceed further, because 10th is the vagus. I told you, carry taste. 9th is glossopharyngeal, which is crystal medicos. Yes, because I have been in the system for last 24 years. I have seen everything almost. You are kids, like kids to me. I started in 2001. I started teaching 2001. It is 2025. I have seen every aspect of these examiner. Maybe I was at AIMS. I have done my MD in anatomy from AIMS, and I was at the other side of the, this wall. We used to prepare MCQs, and what is the psychology of a person who prepares MCQs? See, we are given a simple task. We are given a simple task. They tell us, you prepare a question which only 25% student can answer. Prepare a question which only 25% students. Then they'll ask that why 25%? Because we have 2 lakh students sitting and we have 25,000 seats to give. So if 2 lakh students are coming to me and I have 25,000 seats to give, what kind of question I'll prepare? I have to eliminate people by fooling them, by preparing a question which is too much in depth, or doing something, some cunning things, some shrewd things which normal people, ordinary people cannot. It is deception. It is a game of deception. It is a game of chess. You have to beat the opponent. You students are very much knowledgeable. If I give a question which everybody can answer, then everybody will come. Give me a seat. Give me my seat. So the examiner is also actually, look at his position. He has to prepare such questions. Understand? So, yes, Grace. Yeah, it happens. Like, when you are interacting with people, you start thinking, adopting their methods. But the thing is, see, we should not forget what is our task. Our task is, I am going to become a good doctor, skillful doctor. I have to treat my patients. That is the only thing. You should not forget. I should not forget that I am training you people to become good human, good doctor, skillful doctor. A patient comes, you should be able to treat him and send him back happy. That is the only purpose. This is intermediary thing, and this is just pass. Just you have to cope up with that. You have to train, and these are strategic exams. You have to use strategy. You have to work hard. You have to work smart. And there's only one way of working smart. Keep practicing MCQs as many as possible. That is what we are doing here also. And I keep telling that the examiner have strategy. You just learn the strategy and beat him at his own strategy. That is how you get your rank. Yes, Indu, that is the purpose. So as we are looking at this question, see, look at the questions. And I have taken all these questions from the latest exam. If you have given the latest exam, immediately you'll realize that which exam I'm talking about. These questions are not prepared by me. These questions are taken from the last exam which happened. So, yeah, crystal medicine. Yeah, crystal medico. See, the thing is, of course, I'm teaching anatomy, but I read all the books. I have all the editions of Harrison Medicine starting from 16th edition, 16, 17, 18, 19, 20, 21. I have all the Gray's Anatomy starting from 36th edition of Gray's Anatomy, 42nd, because these days, as such, there are interdisciplinary questions, and there are questions which you start with anatomy, go to orthopedics, start with orthopedics, come back to anatomy, interdisciplinary. So I have to read all those books, of course. Right, okay. So which structure is beneath the arrow mark? So you already know that what is this arrow mark? This is H-shaped structure. So H-shape meeting point of suture, it is pterion. But examiner knows that you know pterion. Examiner knows that what is deep to pterion. So they will keep modifying the options, and sometimes even we get confused. Like with my knowledge of last 20 years it is not last 20 years, means I started MBBS in 93. So it's been 40 years I have been studying anatomy, but still there are questions which I cannot handle, like this question. So, but you have answered, because this is a repeat topic. It is the stem of the Sylvian sulcus. Sylvian sulcus is the other name of lateral sulcus, and that is what you are perfectly all right. That is your thing. But the point is that what about the other option? See, I always tell that you should handle a MCQ like this. What is the answer? Why that is the answer? Why others are not the answers? And when they will become answers? That is how you should deal with any MCQ. When you practice MCQ, what should you do? You should, first of all, find out what is the answer. Then you should find out why that is the answer. Then you should find out why others are not the answer. And then you should find out that when they will become the answer. That is how you deal with one MCQ. So, as Crystal Medico is telling, stem of lateral sulcus, anterior division of middle meningeal artery, middle meningeal vein, correct. Yes, you should know everything about few topics. Let me show you some details now. See, when you go to deep to pterion, it is a surface landmark. A question has already come. It is the anterior division of middle meningeal artery. you can see here, it is the anterior division of middle meningeal artery. So frontal branch or anterior division or middle meningeal. So middle meningeal artery, which is coming from the foramen spinosum, and it is a branch of maxillary artery, all that. So that is the region you are telling that this is the pterion. Another question has come. Already these questions have come. If you have gone through previous question, you will knowing. This is the anterior clinoid process. Let me mark it here. This is anterior clinoid process. It is in the lesser wing of sphenoid. And that question has already come. What is deep to pterion? What is deep to pterion is the anterior clinoid process or lesser wing of sphenoid. Why do you want to know that? Because when we proceed from the pterion, we cut this anterior clinoid, which is called anterior clinoidectomy, to deal with some of the berry aneurysm here in the circle of Willis. So sometimes there is subarachnoid hemorrhage. You plan that subarachnoid hemorrhage, I have to clip the berry aneurysm. Berry aneurysm are in this region, and to reach them, you sometimes cut this. This is anterior clinoidectomy. But your landmark coming from outside, you're coming from outside. So that is again pterion. So what is deep to pterion? Lesser wing of sphenoid or anterior clinoid process. Already this question has come. You can also see this is the lateral sulcus or Sylvian sulcus we are talking about, which is going to separate inferior temporal lobe from the upper frontal lobe and parietal lobe. So there's a frontal and parietal lobe, and they are being separated from temporal lobe by this sulcus. This stem of the lateral sulcus, which is also called Sylvian sulcus, there's a Sylvian point also. Deep to pterion is Sylvian point. So that is the point, Sylvian point or pterion. That is what the examiner is asking here. Also understand, when you are talking about Broca's area is also deep to pterion, but not exactly, because this is the pterion area. See, this is a stem of lateral sulcus. So we are talking about this. Broca's area is also deep to that only. Inferior frontal gyrus, but not exactly deep to it. And Wernicke's is too far behind, cannot be taken into account. So you have to be careful that what other options were given, because next time the examiner will play with the options. So as such, you have given the answer perfectly fine. I have no issue. And I'm telling you, Broca's area may be also nearby, but it is not exactly deep to the pterion. And other things which you have told, anterior division of middle meningeal artery, which you know, it can bleed when there's a fractured pterion. So when there's a fractured pterion, this bleed and there will be this extradural hemorrhage, what is also called as epidural hemorrhage. And that could be life-threatening. So all those things, they are getting repeated again and again. I'll repeat. When there's a fractured pterion, there's one artery, which is anterior division of middle meningeal artery, which can bleed. We have shown that in the diagram, and it can result in extradural or epidural hemorrhage, and which is a life-threatening situation. Just to keep relating things like that. So Crystal Medico is telling clinoidectomy by transsphenoidal approach is also possible. Yes, you can do clinoidectomy by transsphenoidal approach, and you can go for supracellular tumors. Yes, supracellular tumors or this clipping of the berry aneurysm, all that. Okay, so we've proceeded to the next question. It is asking, a child is presenting with cleft lip, planned for repair. Now you must be knowing which exam I was talking about. I have taken this question from that exam only. These are not imaginary questions. These questions have already come to you. And if you have given the exam, you will know that which exam I'm talking about. It's the latest exam. I'm not taking the name because unnecessarily it will create some controversy. So what is the first thing you are going to deal with? Cleft lip is basically the if it is unilateral cleft lip, non-fusion of maxillary process with the medial nasal process. So maxillary process, if it is not meeting with the medial nasal process, you can have cleft lip. You can have even cleft palate. If it is deeper, you can have cleft palate also. So yes, that is correct. Orbicularis oris, because that is the muscle which is around here. You are talking about cleft lip. So cleft lip, you have to actually work upon this orbicularis oris. Let me show you all these muscles which are shown. So muscles repaired in cleft lip surgery. Now, the students who are preparing for these exams like INICET, NEET PG, they think that examiner is going to ask question from BD Chorsia. It doesn't happen like that. Examiner is not asking question from BD. Of course, few questions will come from BD Chorsia also, but examiner is asking questions which are belonging to MCH level. Can you see this question is MCH level question? Though, of course, you can answer it with the knowledge of BD Chorsia also. Sometimes you need common sense. But this question belongs to MCH Oro nasal surgery and all those things. So the very first thing which you have to work upon is, of course, orbicularis oris, and in cleft lip it is disrupted, so you have to work upon that. Number two, it is levator levi superioris. You are elevating the upper lip by some muscle. I'll show you the muscle also. You have to work upon that. Then number three, you have to work upon zygomaticus major minor, the one which pulls the angle of mouth laterally. You are working upon that in a sequence. You have to work. And number four, nasalis. So what I have done here is, I told you, see, whatever I preach, I practice. You should not preach what you do not practice. So what did I preach? Know everything about few topics. You have to know everything about few topics, and this is how you know. So these days you have this artificial intelligence with you. Chat GPT is there. You have this even Google. You have Gemini. Just ask them. Tell them in 5 sentences, tell me the details, and they'll give you the details. So just you can increase your knowledge by that way. It is becoming easier but you cannot blindly depend upon these artificial intelligence apps, because they can make mistakes. They themselves tell that there can be, you counter check the fact. So you should be counter checking fact. Now here in this diagram, as you can see, we are talking about this muscle. This is the orbicularis oris muscle, and orbicularis oris is the first thing which you are going to take care of. So this is the orbicularis oris. Let me shade it, and as you are shading, you see this is the muscle we are going to take care of, number one. Now, if that is the number one, what is number two we were talking about? Number two, the examiner has given you the option, and it is levator levi superioris. So you look at this, levator levi superioris, you have to work upon. You also may be working upon this muscle, which we are talking about, zygomaticus minor and even zygomaticus major. So where are they? They are also inserting here, zygomaticus minor and major. So you are working upon them. Later, because this cleft lip can affect the nasal area also, though it doesn't, because it is lateral nasal process. But if it is affecting, you have to go to this muscle also. Let me change the color, and that muscle will be alegnesi. So that is also a muscle which is coming to the upper lip. So understand that what the examiner is trying to say. This time maybe you have answered orbicularis oris, but next time orbicularis oris will not be in the option. If it is not in the option, what should be your second answer? Always be prepared for second answer, backup answer. Of course, if orbicularis oris is not there, I'm telling you the sequence. Number one, orbicularis oris. Number two, levator levi. Number three, zygomaticus. Number four, alegnesi. Fake smile, vaccinator, true smile, zygomaticus major. Yeah. Do you know rhizorius also? Rhizorius, Rhizus sardonicus. When you breathe nitrous oxide, laughing gas, and your muscles are relaxed, then you give this grin. You must have seen this Arnold Schwarzenegger in Terminator movie, smiling. Fake smile. Rhizus sardonicus, rhizorius. Yeah, crystal medicos, that is correct. It is, if you really want to smile, the human smile, not the Terminator smile, you have to use zygomaticus major, basically. So in this question, in this particular question, we should keep our answer as orbicularis oris. Number two will be levator levi. Number three will be zygomaticus. Number four will be, and this is MCH question actually. And you should not bother actually. Should not bother, because if you cannot answer, nobody can answer. And if nobody can answer, where is the competition? You're competing among yourself, your friends. If your friends don't know the answer, you don't know the answer, doesn't matter. But if the question gets repeat, and you are making mistake, and your friend is getting correct, then you are in trouble. So you shouldn't bother about anything which has come new, because it is new for everybody. But if a question has come and it is repeating itself and you're making mistake, you're losing your rank. You shouldn't make mistake and repeat questions. And that is why you should practice previous year questions. That is the point. Now, this is one question which is asked, that the action to be carried by a muscle which is attaching to the arrow marked area. Now, maybe they have, see, Fazal Shah Khan. Let me tell you one thing. Fazal Shah Khan, let me tell you, Dr. Tamim is my batchmate. We have done MBBS from Bangalore Medical College, Government Medical College of Bangalore. He is my batchmate. He's a very good friend of mine. Dr. Tamim, who teaches medicine in Karnataka, Bangalore. Dr. Tamim used to teach medicine, I used to teach anatomy, the two pillars. You start with medicine, you start with anatomy, and with medicine in MBBS. We are holding the two pillars. I start anatomy and he ends with medicine. We are friends, we are batchmates. We did our MBBS together. And you can if you listen to him and if you listen to me, you can know that we are having the same thinking, because we are in the system. He is still older than, means in the system he is still older than me. He also has that 25 years of experience, and that is what we have. So you have caught it, that there is some similarity between my way of teaching and Dr. Tamim's teaching. So here, as you are looking at this arrow mark region, see, this is the arrow mark region. It is basically the butterfly you are talking about. There's a butterfly bone, which is the sphenoid bone. You're looking at the butterfly from lateral side. So what about this butterfly? It is sphenoid bone. You are talking about sphenoid bone. And when you are talking about sphenoid bone, you will see that sphenoid bone is basically, the sphenoid bone is having a body. It has a lesser wing, it has a greater wing, and it is having this feet, and those feet are called as pterygoid plates. And you are looking at pterygoid plate here. But this is from the front view. If you look from the front view, how will you find sphenoid bone? Sphenoid bone will have a lesser wing attaching to the body. It has a greater wing attaching to the body. It has legs also. And those legs are called pterygoid plate. Now, pterygoid plate also, there will be lateral plate and medial plate. And when you are looking at the lateral plate of lateral pterygoid plate, you will find there are two muscles coming. One which is coming from the lateral side, it will be called lateral pterygoid. And there'll be one which is coming from medial side, and that will be called medial pterygoid. So there are two muscles basically coming from here. If you're looking from the lateral side, it will be lateral pterygoid. But if you look from medial side, it will be medial pterygoid. Since the arrow is showing such way, I will assume that they are asking about lateral pterygoid. Let me zoom this area. You have to understand that we are talking about, see here also you can see this is the greater wing of sphenoid. That is the greater wing of sphenoid. And this is the leg of the butterfly. And that is pterygoid plate. Pterygoid plate, if you are looking laterally, it will be lateral pterygoid. And if you look medially, then it will be medial pterygoid. Basically, question is on lateral pterygoid. But even if you have identified that fact, still you may not be getting answer. Why? See, this is lateral pterygoid plate, from where you are having this lateral pterygoid muscle originating. It has two heads, a transverse and oblique head, and one is attaching to greater wing also. So these are the two heads which you can show. There is one which is attaching to the greater wing, and there is one which is attaching to lateral pterygoid plate. But where is the insertion? Because if you're talking about the movement, the origin doesn't move, it is the insertion which moves. So where is insertion? Insertion is to the pterygoid fovea, which is, at the neck of the mandible, below the condyle process. And number two, it is to the articular disc also. When this muscle goes into spasm, there can be TM joint dislocation also. It can pull the mandible forward. So it is pulling the mandible forward, but it is written by Gray's Anatomy. Maybe it is pulling the mandible forward, but it is for the purpose of depression. So it has two actions basically. This muscle has two actions. It is for protrusion and it is also for depression. But look at the Gray's Anatomy, and you'll find that it is doing protrusion just for the purpose of depression. So this is your first answer. Preferable answer, if you ask me, is depression. Maybe it is also a protruder, but what is it protruding for? For depression. So this is not a simple question again, and a lot of questions come from the same topic. Muscles of mastication is one important topic, so you should work upon that. I'll keep my answer as depression, as it is working for depression. You will depress the mandible to open the mouth. So you want to open the mouth, and for opening the mouth, because other muscles, if you look at them, they are MTM elevators. What do you mean by MTM elevators? Maybe it is the masseter, or maybe it is the temporalis, or maybe it is the medial pterygoid. They are going to close the mouth. They're going to close the mouth. So if you want to close the mouth, you can use MTM elevators, which are elevating the mandible to close the mouth. So maybe it is masseter or temporalis or medial pterygoid. They work for this muscle. This lateral pterygoid is actually antagonizing those three muscles by depressing the mandible to open the mouth. So the only possible answer here is means there is another answer. You can always tell that it is a muscle for protection also. But why does it do protection? Read Gray's Anatomy, you'll know that the answer should remain depression. Yes, and of course, like if you want the other actions, you can remember it will aim the mandible. Aim the mandible means it'll take the mandible anterior, it'll take the mandible inferior, and it'll also take it medial. That is why what happens is that the two lateral pterygoid, they balance each other. The two lateral pterygoid, they balance each other because they pull the mandible medial. Say it will protrude the mandible, it will depress the mandible, it will aim the tongue, aim the mandible, anterior, inferior, and medial. What will happen if right-sided trigeminal is not working? What will happen if right-sided trigeminal is not working? If right-sided trigeminal is not working, right-sided lateral pterygoid not working. If right-sided lateral pterygoid is not working, what the left lateral pterygoid will do? It'll keep pulling the jaw, and jaw will deviate to the same side of lesion. It is just like tongue deviates to same side of lesion. In the tongue, the genioglossus work for aiming the tongue, and in the jaw, mandible, it is the lateral pterygoid which will work for aiming the mandible. So if right-sided 12th nerve is gone, the genioglossus of left will deviate the tongue to the same side of lesion. And if 5th nerve is not working, then the lateral pterygoid of normal side will pull the jaw to the same side of lesion. Jaw deviates to the same side of lesion because of opposite lateral pterygoid, same way as tongue deviates to same side if opposite genioglossus is more powerful, that way. Yes, crystal medicose, protraction, depression, and medial movement. That is correct. Ipsilateral deviation of tongue and jaw whenever there's a lesion of any nerve, maybe 5th nerve or 12th nerve. Yes, correct. Now, as we are moving further, this is one question they are asking, referred pain. This is about referred pain, which is from the dura mater, which is in the arrow mark region. So where is the arrow mark region? It is around the foramen magnum, posterior cranial fossa. So you are in the posterior cranial fossa around the foramen magnum, and they are asking that if dura mater is inflamed, say for example there's a tumor which is inflaming or there may be meningitis, simple meningitis. So if dura mater is involved, then where will be you have to understand that this is posterior cranial fossa, and in the posterior cranial fossa, the nerve supply can be cervical C1, 2, 3. Now, when you're telling cervical C1, 2, 3 is supplying here, also understand that C1, there is no dermatome in our body. C1 it doesn't supply the skin. So if it doesn't supply skin, you cannot have pain referred on the skin with C1 root value. So you have to talk about C2 and C3. So where is C2, 3? And you are focusing upon the options also. Is it going to the vertex? Vertex means somewhere here, but vertex is the region where you will have pain because of cranial nerve number 5, the first division, ophthalmic division. It is ophthalmic division which is sending the pain to the vertex, not the cervical nerves. So what about the ear? Ear, greater auricular nerve. Greater auricular nerve is having that root value C2. So you can have C2 and 3, you can have pain on the ear also. But then, is it more specific for this region or not? That is the point. What about the back of head? I think the best answer will be back of head. Best answer will be back of head because, of course, it can also go to the back of neck as well. But then back of head and ear appears to be better options where I can go for. You see here, when you are talking about the dermatomes, you will find that the greater auricular nerve supply greater part of the auricle, and it has root value C2, 3. So pain can definitely go to the ear. There is no doubt about it that if we are talking about the greater auricular nerve and C2, 3 root value, pain can be there because the dermatome is C2, 3, which is the same root value as the dura mater being supplied. Otherwise, you can say the greater occipital nerve, which is on the back of the head, the third occipital nerve, which is on the back of the head, they appear to be better answer. Means this can be answered, that can be answered. You cannot answer it as back of the neck. Why you cannot answer it back of neck? Because back of neck, you can see it is root value C4 to 8. So if it is C4 to 8, back of neck, you cannot answer it as back of neck because what is the dermatome value you are suspecting, because C1 to 3, C1 there is no dermatome, so you are talking about C to 3. Now that C to 3 could be the ear, or that could be this area. So what will you answer? Will you answer it as ear, or will you answer it as the back of the head? That is the point. I will choose my answer as back of head. You see, I have given you a table. Back of head, because greater occipital nerve and third occipital nerve, posterior rami, basically posterior scalp occipital region, is correct. Why not the ear then? What about the ear? Ear, you have other nerves also. Auriculotemporal nerve, the mandibular trigeminal, auricular branch of vagus also, and glossopharyngeal also. Of course, you have greater auricular nerve also. Along with that, you have these nerves also. So it becomes kind of diluted. It becomes kind of diluted, and you cannot say no connection. How can you say no connection? It is basically, if you're talking about these nerves, auricular temporal, auricular branch of vagus, glossopharyngeal nerve, if you're talking about these nerves, then there is no connection. But then greater part of auricle is supplied with greater auricular nerve, and it is a connection. I could have taken ear also as my answer, but it is getting diluted by additional nerve supply. Why not vertex? I told you vertex is ophthalmic trigeminal, cannot be the answer. And what about the back of neck? Back of neck is C2 to C4. Our root value is C1 to 3, so it doesn't fit well. So only thing which fit well is pure answer. If you want, then it will be back of head, and that is what I have given as the answer. It is choice number C. That is what. This is the question which is asking us about the area here. Posterior canal fossa. Posterior canal fossa root value is C1, 2, 3. That is the durameter being supplied by cervical 1, 2, 3. And the fitting well answer is back of head. Yeah, so Fazal Hassan, he will be praising me, of course, because I am praising him, because not because we are friends, because we know that we work hard. We are working hard. We have been working hard since long, and praise is inherent, means I cannot praise people just like that. I will praise only if I find something good in them. That is the instinct which I have. So yes, that's what. The way the questions are asked, we teach the same way, and that is how you reach your answer faster. The way we teach, yes. Repeat questions are dangerous, yes. But if you handle them perfectly, then they are your allies. Okay, what about this question now? This is 50-year-old male who is presenting with right-sided neck pain. There's a right-sided neck pain radiating to right ear. So referred otalgia. This is a case of referred otalgia. So there is a case of referred otalgia. And as you can see, why 5-1 association pain referred to vertex? See, 5-1, if you're talking about this nerve 5-1, is supplying the durameter in the anterior cranial fossa. So if there is some durameter problem in the anterior cranial fossa, maybe the pain will be referred to here. See, trigeminal nerve, who is supplying this upper eyelid, vertex, and the forehead area. The trigeminal nerve ophthalmic will supply upper eyelid, forehead, and the vertex area. That is ophthalmic trigeminal. If you say lower eyelid and the upper lip, that is maxillary division of trigeminal. If you say lower lip and mandible, that is mandibular trigeminal. If you look at the face, you'll find upper eyelid, forehead, and vertex. This is ophthalmic division of trigeminal. So if you're asking me about vertex, ophthalmic trigeminal, if there was something wrong with the durameter in the anterior cranial fossa, then you'll have the even middle cranial fossa midline, near the midline. Near the midline, middle cranial fossa durameter is by ophthalmic, and that is not posterior cranial fossa. This nerve doesn't come to posterior cranial fossa, and our question was on posterior cranial fossa. So if you're asking me, like Crystal Medicos, you're asking 5-1 association refer to vertex, because this is the territory of ophthalmic trigeminal. This all area is ophthalmic trigeminal. Angle of mouth is greater auricular nerve. Yes, angle of mouth and greater part of auricle is greater auricular nerve. C2, C3, more precisely C2. That is why I was thinking that why not take the answer as ear. The pain will be felt in the ear also. But ear has other nerves also getting diluted. So specific answer, better say back of head. Okay, what about this question then? As you are looking at this question, you see there is a foreign body sensation and discomfort, difficulty on swallowing. Something wrong with the, swallowing. So pharynx maybe. Laryngoscopy, so laryngopharynx. And fishbone, then you know what we are talking about. Fishbone can be there in piriform fossa, piriform fossa. So we are talking about piriform fossa here. And irritation of which nerve? So which nerve supply the piriform fossa? You know, the posterior-most tongue, epiglottis, and piriform fossa, they have same nerve. The posterior, because they are belonging to fourth arch. So in the fourth arch, some things are developing. The posterior-most tongue, it is the posterior-most tongue which will develop in the fourth arch. It is the epiglottis which will develop in the fourth arch. Even the area of piriform fossa is supplied by, so the nerve of fourth arch. Who is the nerve of fourth arch? It is superior laryngeal nerve. But superior laryngeal nerve is motor also. It is external laryngeal nerve which is motor to cricothyroid muscle, and it is also internal laryngeal nerve. So we are basically talking about internal laryngeal nerve because it is sensory nerve. It is sensory to vocal cords also, sensory to the larynx, sensory to the larynx till vocal cord. So sensory to the larynx till vocal cord, because below the vocal cord, it will be basically recurrent laryngeal nerve. Below that is recurrent laryngeal nerve. So let me repeat the thing. You are having a 50-year-old male with piriform fossa irritation. So which nerve? Piriform fossa or posterior-most tongue or epiglottis, they belong to fourth arch area. So which is the nerve of fourth arch? Nerve of fourth arch is superior laryngeal nerve. But superior laryngeal nerve has two parts. It is external laryngeal nerve supplying cricothyroid muscle, tensor of vocal cord. Are you talking about that? No, it is sensation. So if you're talking about sensation, then internal laryngeal nerve. Internal laryngeal nerve is sensory to the larynx till vocal cord, because below vocal cord you'll have recurrent laryngeal nerve, but above vocal cord you have superior laryngeal nerve. So that is the area you are talking about. Posterior-most tongue, epiglottis, piriform fossa, vocal cord, superior larynx. All that is this nerve. So that is why you will keep your answer as internal branch of superior laryngeal nerve. Internal branch of superior laryngeal nerve. As you, Tisal Medical is telling, the cuff reflex. Yeah, cuff reflex is maybe initiated by that fishbone, or maybe anything which goes into that area which is irritant. Even if some fluid enters the larynx, there'll be a cuff reflex. Which nerve giving you cuff reflex? The same nerve, internal branch of the superior laryngeal nerve, nerve of the fourth arch. Because this is, we are talking about posterior-most tongue also, which develop in fourth arch. Epiglottis develop in fourth arch. So with that area, you are looking at a coronal section. You have taken a coronal section, remove the anterior part of the head region, and look at the front view of the remaining part. You see, this is the nerve we are talking about. This is the nerve we are talking about. The nerve is internal laryngeal nerve. And you can also look at the course. Internal laryngeal nerve, which is a branch of the vagus superior laryngeal nerve. So vagus branch, superior laryngeal nerve give internal laryngeal nerve. And you can see this is the region of piriform fossa. You can shade the area of piriform fossa. This is the region of piriform fossa. And it is also called smuggler's fossa. Why it is called smuggler's fossa? Because some of the smugglers, what they do is they utilize it for carrying something like diamonds. They can put diamonds. Putting diamonds into that area, later they can retrieve the diamond once they are through the airport checkup and all that. So that is the piriform fossa you are talking about. And here it is the internal laryngeal nerve you are talking about. Look at the course of internal laryngeal nerve. Internal laryngeal nerve is in the territory of piriform fossa. That is why if you see that a fishbone came here, if a fishbone came here, that can damage this nerve. And if this nerve is damaged, you will not have, the patient will not have cuff reflex. That is dangerous. So it is a protective nerve and it should not be damaged. You should remove that carefully. Means while removing fishbone, you damage the nerve, there'll be a problem. If you damage internal laryngeal nerve, the patient will not have cuff reflex. Some fluid will enter and it might go into lungs also. So this nerve has to be protected while operating. And why there was pain in the ear? Why referred otalgia? Because auricular branch of vagus. Auricular branch of vagus supply here. That is called referred otalgia. If this nerve is compromised, it is a branch of vagus. And vagus also give auricular branch of vagus. So it could be related from here to here. See, when you do syringing, ear syringing, why there is cuff reflex? When you do ear syringing, at the floor of the external auditory meatus, you have auricular branch of vagus. And if you irritate the auricular branch of vagus, there can be cuff reflex. So that is the relation. A problem here can go there, referred pain. A problem from there can come here, So they are interrelated. They are all vagus branches. That is the point. So we'll keep our answer as the internal branch of superior laryngeal nerve. Now, as we are moving further, you look at this question. 3-year-old child, history of cyanosis since infancy, congenital cyanotic heart disease, and diagnosed with tetralogy of Fallot. Tetralogy of Fallot. You know why tetralogy of Fallot happens? It can happen in DiGeorge syndrome. So what is the problem in DiGeorge syndrome? DiGeorge syndrome, there is a problem with neural crest cells. The neural crest cells don't migrate properly. If neural crest cells don't migrate properly, you can have episeptum anomalies. And one of the episeptum anomaly is the tetralogy of Fallot. Tetralogy means 4 component will be there. So we can just quickly revise that it is a congenital cyanotic heart disease, tetralogy of Fallot, and it is one of the feature of DiGeorge syndrome. In DiGeorge syndrome, when there's a problem of neural crest cell migration, as neural crest cells are not migrating properly, there'll be episeptum anomaly. Episeptum anomaly, one of that is tetralogy of Fallot. What happens in tetralogy of Fallot? There is anterior migration of episeptum, and because there is anterior migration of episeptum, you'll find there is a truncus arteriosus, and that truncus arteriosus has to develop this episeptum, and if the episeptum is migrating anterior, means towards the pulmonic area, there'll be pulmonic stenosis, and that is the answer. There'll be pulmonic stenosis, that'll be the answer. Infundibular area is pulmonary trunk beginning, and it is around the valve, pulmonary trunk valve. So as you go through the details, tetralogy of Fallot. Why do we have tetralogy of Fallot? Because there is anterior migration of episeptum. What is episeptum? There is a structure called truncus arteriosus. In the truncus arteriosus, they'll be developing episeptum, dividing it into aorta and pulmonary trunk. So that is why the name is episeptum, aorta pulmonary septum. If this episeptum migrate anteriorly towards the pulmonary trunk will become narrow, pulmonic stenosis, and that is the answer. Let me give you more details, but yes, you distal medicose, you are telling Arnold's nerve, Jacobson's nerve. Yes, that is referred pain or referred otalgia. Yes. Neural column topic is confusing. Neural column topics, I must have put some YouTube videos. You can watch them. It is difficult. It is difficult, and the questions keep coming from neural columns. That is understood, but the way I teach, it becomes a bit easier to manage. So prov, you can remember prove. Actually, instead of prov, you remember prove. Prove, prove. That'll be better. Mnemonics are also should be like what you can remember. So DiGeorge syndrome is PP3 problem. Yes, DiGeorge syndrome, you can have pharyngeal pouch 3 problem. Pharyngeal pouch 3 is not working. So thymus is absent. The inferior path heart is absent. So in DiGeorge syndrome, there are a lot of problems. And one of the problem will be pharyngeal pouch 3 is missing. As pharyngeal pouch 3 is missing, thymus is missing, inferior path heart is missing. So they are all problems of DiGeorge. But this episeptum anomaly is also a problem of DiGeorge syndrome only. So this is the tetralogy of Fallot. What happened is that this vessel, which is pulmonic stenosis, why it happened? Because there is anterior migration of episeptum. So when there is anterior migration of episeptum, there will be pulmonic stenosis. Now, what is the problem if you have pulmonic stenosis? If you have pulmonic stenosis, the other vessel, which is aorta, will become large. If one of the vessel is becoming smaller, the other vessel become large because septum is between them. So between them you have the septum. If septum migrates anterior vessel is narrow. What about the posterior vessel? Posterior vessel become large. It is so large that it is overriding the interventricular septum. As it is overriding interventricular septum, you say that because the aorta is large now, because the aorta is large, it is overriding the interventricular septum. It is opening into both the chambers, the right ventricle as well as left ventricle. It is a left ventricle which is sending blood into aorta, and it is the right ventricle which is sending blood into aorta. What will happen now? What will happen is number 3, the ventricular septal defect. There will be a ventricular septal defect. Why there is a ventricular septal defect? There is a ventricular septal defect because of the overriding aorta. If the aorta, see, normally aorta should open here. But if aorta is opening here also, you are creating a ventricular septal defect. So there will be a ventricular septal defect. What will be the fourth thing? Fourth thing is, look at the poor right ventricle now. It is undergoing hypertrophy. It is becoming thicker than the left ventricle. See, Normally left ventricle is thicker, but here look at the right ventricle. It has become thicker than the left ventricle, which is strange. Normally, what is the ratio? Normal ratio is 1:3. 1:3 means right ventricle, left ventricle. Because right ventricle has to send blood into the lungs, but left ventricle has to send the blood to the system. So it is thicker normally. But look at the thickness now. Left ventricle, the right ventricle is 3 times thicker now. But why? Why the right ventricle is undergoing hypertrophy? You can understand 2 reasons. Reason number 1. The right ventricle trying to push blood into this narrow vessel, which is pulmonary stenosis. So it has to work more, isn't it? If the right ventricle is pushing the blood into this narrow pulmonary stenosis, it has to work more. It will undergo hypertrophy, number 1. Number 2, it is sending blood not only into pulmonary trunk, it is sending blood into ascending aorta also. And since the right ventricle is sending blood into ascending aorta has high pressure blood. Ascending aorta has high pressure blood. You have to push blood into ascending aorta. You are pushing against the high pressure. Obviously, this will again result in right ventricular hypertrophy. And there is a pentology of Fallot also. In pentology, you have ASD also, atrial septal defect. So there's a case of pentology Fallot, and there'll be atrial septal defect also. But the question is asking about tetralogy. So if it is tetralogy, we'll keep our answer as infundibular stenosis. Now, why you are telling infundibular stenosis? What is this infundibular stenosis? You know, this is the pulmonary trunk you are talking about. Pulmonary trunk will have a valve. That is pulmonary valve. It could be subvalvular narrowing. It could be valvular narrowing. It could be even beyond the valve. So usually it is before the pulmonary valve, there is a narrowing, but it can be under the valve. It can be over, even distal to the valve, but it is infundibular region, which is more common. Is you say subpulmonic stenosis also. Remember these terms, subpulmonic stenosis or infundibular stenosis. That is what. And ASD, as I am telling, that ASD can be there, but it is pentology of Fallot. That will be now one more additional thing. So pentology of Fallot, you can say that maybe it is there. Otherwise, LVH was there. Transposition of great vessel is happening if there is, if there is transposition of AP septum. It is also AP septum anomaly. That is also AP septum anomaly, and it can happen that if the great vessels are transposed. See, why this happens is, if it is AP septum anomaly, why? If AP septum is not spiral. If AP septum is not spiral, then there will be transposition of great vessels. So these are all AP septum anomalies. If the normally AP septum is a spiral septum. If it is not spiral septum, that is why, pulmonary trunk and ascending aorta are spiral. Pulmonary trunk, ascending aorta, they are spiral. Why they are spiral? Why they are not straight? Because the septum between them, AP septum is spiral septum. What if it is not spiral? Then they'll become straight. And if they become straight, then what is that called? Transposition of great vessels. So transposition of great arteries is also AP septum anomaly only. If the AP septum is not spiral, vessels are not spiral, which normally they should be, and that will result in transposition great vessel. But here, they already have given tetralogy Fallot. So we don't need to think all that. We just keep our answer as infundibular stenosis. FMGE, BTR enough. FMGE, BTR enough. BTR, बुरी तरह रटो. बुरी तरह रटो आपके काम का है, पर पहले आपने कुछ तो रटा हो, तभी तो कुछ और रटोगे. BTR is a good session. There is no doubt about it. But you should have some basic knowledge. You should have some basic knowledge. If your basic knowledge is good, BTR is good. But if you do not have the basic knowledge, then what the BTR? Madam is teaching you quite perfectly fine, though I have some reservations about my comment. But BTR is good. There's no doubt. If you ask me enough, sorry, it is BTR is good, but BTR is not enough. I have tremendous respect for the madam who is taking BTR, and she's doing a good job. But students are thinking that BTR is enough. She never tells that BTR is enough. She tells that you prepare well and then come to me. I'll revise everything in 2-3 days. So that way BTR is good, but BTR is not enough. If your question is it enough? No, it is not. Okay, look at this question now. As you are looking at this question, match the following. You can see immediately that we are looking at lungs here. This is lungs, because you usually see inferior to superior. So this will be right lung, that will be left lung. You can mark them. So this is going to be the right lung and inferior view. This is the left lung, inferior view. But then you see that the markers are on some chambers. So that must be the heart in the mediastinum, middle mediastinum, the heart. Let us zoom. As you zoom here, you'll find this is the vertebra. Must be thoracic vertebra. Must be thoracic vertebra because you're in the thorax. You're in the thorax because these are the lungs. If these are the lungs, you are in the thorax. And this is the heart. Now, this is the heart. Which chambers are we looking at? Remember, sternal, costal surface, more to the left side. Heart is more to the left side. So sternal and costal surface, which chamber is there? Right ventricle. That is right ventricle. So when you look at the sternum and the costa, more to the left side, sternocostal surface is right ventricle. B is right ventricle. Now, if you say B is right ventricle, let us put the marker. This is right ventricle, fine. What about the right atrium? Right atrium forms the right border of the heart. It forms the right border of the heart. So this is the right border of the heart. Right border of the heart formed by the right atrium. This is a vessel entering into right atrium. Vessel entering into right atrium, that is superior vena cava. Even the superior vena cava contribute to right border of the heart. So when you look at the right border of the heart, you'll see not only right atrium, but also superior vena cava contribute to that. Okay, what is just close to the vertebra? The chamber which you cannot see from the front view. So which chamber you cannot see from the front view? Left atrium. So why you cannot see left atrium from the front view? Because it is posterior, related to the vertebra. So if it is related to the vertebra, where is the left atrium? I can mark the left atrium now, and you can see the blood vessels also entering it. So some blood vessels entering it. So what blood vessel is that? Pulmonary veins, pulmonary veins. Let us mark the pulmonary veins now. You see, these are the pulmonary veins which are entering the left atrium. This is the left atrium, which is receiving pulmonary veins. Now, if you say that this is the arrow mark D is the left atrium because it is the more posterior structure. What about this marker C? What about this marker C? You have to go through several sections of thorax, then you will realize that marker C, which is right in the center. Can you see it is right in the center? Marker C is right in the center. It is a continuation of this chamber. This chamber. Which chamber? The chamber which forms the left border of the heart. So which chamber forms the left border of the heart? Actually, you are looking at what is called as the ascending aorta, and ascending aorta coming from left ventricle. Now, since these markers are overlapping, you cannot see things clearly. Let me take you to this diagram. This diagram, then it will become more clear. I'll mark again. Who is forming the right border of the heart? The right atrium and superior vena cava. Who is forming the sternocostal? This is the sternum and the costa. So who is forming sternocostal surface? This chamber, which is right ventricle. And who is forming the left border of the heart? This chamber, which is the left ventricle. From the left ventricle, you are getting this, which is ascending aorta. That is ascending aorta. And what about this here that we are telling? This is a vessel entering here into this chamber, which is shown here, a vessel entering from there also. So right pulmonary vein and left pulmonary vein into the left atrium, into the left atrium. So you have identified left atrium here, and you have identified the ascending aorta here, which come from the left ventricle. You have identified here right ventricle. You have identified superior vena cava, which is entering the right atrium. With that information, I think it should remain on YouTube. It should remain Crystal Medicos. It should remain on YouTube. So with that information, you can see, look at the, your answer is choice number C. And why? Let us see. See, receive oxygenated blood. Who receives oxygenated blood? The left atrium. So if it is left atrium, then what is the marker? Marker is D. Then hypertrophies in pulmonary stenosis. We have just discussed the tetralogy of Fallot. Who was hypertrophying in pulmonary stenosis? Right ventricular hypertrophy. So where is right ventricle? B. That is marker B. Then arises from the left ventricle. Who is arising from left ventricle? ascending aorta. That is ascending aorta. So ascending aorta, what is the marker? C, marker C. And what about this lies to the right side of ascending aorta? To the right side of ascending aorta. It is superior vena cava, no doubt. It is choice number A. But let me show you, you keep your answer as choice number C. But let me show you one thing here. You have to remember this relation also in the heart. What relation? You should remember superior vena cava entering right atrium is to the right side. If you look from the front view, the superior vena cava, let me mark also. Superior vena cava is to the right side. It is to the right side. As you look at the superior vena cava entering the right atrium. After that, the left ventricle sending ascending aorta. It is the left ventricle sending ascending aorta. So ascending aorta is sandwiched in between. It is sandwiched in between. When you say it is sandwiched in between, it is sandwiched in between what? It is sandwiched in between what? That I'll tell, but just keep the idea that it is sandwiched in between. It is sandwiched in between a vessel which was to the right, which is the superior vena cava. That is a vessel to the right, which is superior vena cava. And look at one vessel which is to the left side. So which vessel is to the left side? You can see the right ventricle sending the pulmonary trunk. It is the right ventricle sending the pulmonary trunk. So where is pulmonary trunk? This is pulmonary trunk. Now, if you say that is pulmonary trunk coming from right ventricle, and that was the ascending aorta, basically, ascending aorta coming from the left ventricle. The three vessel relation. Remember the three vessel relation. Whenever you get a transverse section, you will find them there. So what is the three vessel relation? Superior vena cava is to the right side. Ascending aorta is sandwiched in between. And pulmonary trunk is to the left side. But why pulmonary trunk is to the left side? Because that is how the pulmonary trunk goes. It goes to the left side. But why the ascending aorta is to the right side? Because that is how it goes. It is to the right side. And why superior vena cava is here? So remember these relations. Superior vena cava entering right atrium. The right ventricle sending pulmonary trunk, which moves towards the left side, and left ventricle sending the ascending aorta. This three vessel relation you have to remember. In your question, the option was a vessel to the right side of ascending aorta. A vessel to the right side of ascending aorta. Who is that? That is superior vena cava. That was in your option. So you see here in this lies to the right of ascending aorta. Who is that? That is superior vena cava. Marker is A. That is why we have kept our answer as choice number C. Moving on to the next question. It should come as a simple question because see, even in the exam, not all questions are tough. There are some simple, easy questions. Even in my sessions, I'll keep some simple questions. Why would you? Yes, Fazal, sure. Of course, surgery becomes easy and conceptual if your anatomy is good. So why do we keep simple questions? So that you don't get disheartened. See, we have to bend you, but we should not bend too much so that you break. So examiner is also like that. They have to give tough questions, but not all the questions are tough. So in my session also, I'll not keep all the questions tough. But some students may say, sir, this is also a tough question. Then you have to work upon your basics. Can you give the answer? It is simply asking muscle is not being supplied by deep branch of ulnar nerve. Ulnar nerve supply 1.5 muscle in the anterior forearm and most of the muscle in the hand. But then it is not supplying muscles which are towards the thumb, especially if you're talking about this muscle, opponent's pollicis. So opponent's pollicis, though some books may say that few branches from ulnar, but it is mostly supplied by median nerve. I'll show a diagram also, mostly supplied by median nerve. What about the others then? Lumbrical, if you say lumbrical 1 and 2, they are by median nerve. If you say lumbrical 3, 4, they are by ulnar nerve. So this is third lumbrical, ulnar nerve. What about the abductor digiti minimi? It is hypothenar area. Hypothenar area is ulnar nerve area. So hypothenar nerve muscles are supplied by ulnar nerve, no problem. What about the interossei? There are 8 interossei. Grace is telling after looking at tough question, we forgot easy questions, sir. Main problem is anxiety. To take care of that anxiety, you keep giving grand test. Whatever anxiety is there, you develop tolerance to that. There's only one way out. If there is a fear, you face the fear and go beyond the fear. डर के आगे जीत है, डर के आगे जीत है, एंजाइटी के आगे जीत है. You should face the problem head on. Give grand test and keep failing, keep getting low rank. Don't worry, you'll improve, you'll improve. That anxiety should not be there in the actual exam. In the exam hall, you should be. Let me tell you one of my experience. In my 10th standard, people told me that 10th standard, this is somewhere 90s, you know, 10th standards, the teachers and my friends and everybody telling me board exams are very difficult and it is very difficult. Then I am telling, oh, it is very difficult. And I'm preparing. I have prepared all the previous questions. I have, in maths, I have done 5 guides in addition to my NCRT book and all that. I'm totally fully prepared. And when I go to the exam hall, I find the paper is so easy. Paper is so easy. Hey, I know the answer to this question. I know the answer to this question. Paper is so easy. Then I'm wondering, sitting in the exam hall only, I'm wondering then why people used to say that this 10th standard papers are difficult. In any exam, like English also, social studies, Hindi, all of the papers appear. I was afraid of maths, actually. I'm talking about maths because I was afraid of maths. But the paper appeared. So paper appeared easy to me because I was prepared. That is the point. When I came out of the class, everybody is telling paper was so difficult. It was so hard. We could not answer this. And I'm wondering, what is this? What is wrong with these people, or something wrong with me, or I have answered wrong. Something is wrong. Then result came. Result was good. I got more than 75%. In my time, getting more than 75% in anatomy for a person who is willing to become a doctor was something good. Not many people got more than 75. I got 78 actually out of 100. Now you're wondering what's getting 78 out of 100. What big deal is there? We get 99.99%. Yeah, this era is different. That era was different. And moreover, I was more interested in biology than mathematics. But still I got 78. And paper was easy for me. But why the paper was easy for me? Because I was prepared. So as you are telling that you are feeling anxiety, yes, it is a natural thing. You should feel anxiety. You should feel fear. But that should not paralyze you. It should be positive. You should become stronger, better. And how do you do that? You practice, keep practicing. I told you just now, 5 guides I did in addition to the normal NCRT. So I prepared myself. I went ahead of the fear. And everybody's telling the paper was difficult. I'm telling you, what is this? Paper is difficult. Paper was very easy. Why the paper was easy? Because I was prepared well. So you be prepared well. That is the point. So dorsal interosseous, all interosseous, 4 palmar, 4 dorsal interosseous, all the 8 interosseous are supplied by ulnar nerve only because it is a deep branch. These muscles are very deep. Deep muscles, deep branch, all interosseous supplied by the ulnar nerve. You see this diagram. The ulnar nerve passes behind medial epicondyle, supply 1.5 muscle in the anterior forearm, which is flexor carpus ulnaris and medial half of FDP. This medial half of FDP also give you lumbrical 3, 4, lumbrical to the finger number 4, 5. So they are also supplied by ulnar nerve. We are talking about ulnar nerve supply. Ulnar nerve supply 1.5 muscles in the anterior forearm, almost most muscles of the hand, except thumb side, because thumb side you have median nerve. But it will supply one deep muscle of thumb also, that is adductor pollicis. It is supplying one deep muscle of thumb, which is adductor pollicis. It is also supplying deep head of the flexor pollicis. So it doesn't mean that thumb muscles are only supplied by median nerve. If you look at one of the thumb muscle, adductor pollicis, it is supplied by ulnar nerve. And look at the deep head of the flexor pollicis, it is also, so it is a hybrid muscle. This is a hybrid muscle because it will have 2 supply. Superficial head by median nerve and deep head by ulnar nerve. If you're talking about deep branch of ulnar nerve, it will supply all the muscles in the hand except for palmaris brevis, because palmaris brevis is superficial. It will be superficial branch of ulnar nerve. So palmaris brevis superficial branch of ulnar nerve. Otherwise, all the other muscles in the hand which are supplied by ulnar nerve are deep branch, like the 4 palmar interossei or 4 dorsal interossei. They're very deep muscles or deep branch of ulnar nerve. So this is what the ulnar nerve is supplying, and whatever is left will be supplied by median nerve because there are only 2 nerves here. Either you supply by ulnar nerve or you have median nerve. And if you remember what the ulnar nerve is supplying, whatever left will be supplied by median nerve. So whatever we have not discussed here will be supplied by median nerve. Anyhow, here your answer is choice number B, because opponent's pollicis is supplied by median nerve. It is not supplied by deep branch of ulnar nerve. Okay, look at this question. During a laparoscopic cholecystectomy, there is this hepatocystic triangle. Hepatocystic triangle. People call it as Callet's triangle, but it is wrong. It is not Callet's triangle. Callet's triangle is different, and hepatocystic triangle is different. Don't confuse between the two. And if you say Callet's triangle, you should have to tell modified Callet's triangle. Then you should use the term modified Callet's triangle, because I'll show you the actual Callet's triangle is different and the hepatocystic triangle is different. They're not the same thing. If you have to use the term Callet's triangle, you should use modified Callet's triangle. So what is the difference? Difference is, this is the hepatocystic triangle. So if this is the hepatocystic triangle you're marking, if you are marking this as the hepatocystic triangle, then what are the boundaries? Boundaries you can see for yourself will be common hepatic duct and the inferior border of the liver and the cystic duct. So why should I know about these boundaries? You should know about these boundaries, because inferior border of liver, because you are operating on the patient. You wanted to remove gallbladder. If you want to do cholecystectomy laparoscopically, especially laparoscopic cholecystectomy, if you want to do laparoscopic cholecystectomy, you will have to mark out this structure. What is that? Cystohepatic triangle. Cystohepatic triangle or hepatobiliary triangle, whatever. But this is not Callet's triangle. If this is not Callet's triangle, then where is Callet's triangle? And what are the boundaries of a cystohepatic triangle? It is inferior border of liver, the common hepatic duct, and the cystic duct. What are the contents? Contents are right hepatic artery, which is giving cystic artery, and one lymph node. So you can see the contents of cystohepatic triangle. If you're looking at the content of cystohepatic triangle, cystic artery, which is given by right hepatic artery, and then you have the lymph node also. But I am telling you, this is not the Callet's triangle. If this is not the Callet's triangle, then what is Callet's triangle? Let me show that now. Look at Gray's anatomy. You'll see Gray's anatomy mentioning that Callet's triangle is isosceles triangle. You remember your geometry, isosceles triangle. And it is common hepatic duct. Cystic artery is the boundary. And cystic duct is the boundary. It is 1864, 1914. That means cystohepatic triangle is not Callet's triangle. Now, it is further given by Gray's anatomy that the cystohepatic triangle is the triangle which is between cystic duct, common hepatic duct, and inferior surface of liver. People are often mistakenly referring it as Callet's triangle, which is not. It was found by Stringer 2009. Stringer told that, what man, this is not Callet's triangle. Callet's triangle is an isosceles triangle and it is different than the cystohepatic triangle. So what is the cystohepatic triangle and what is the purpose of that? It is written here. Laparoscopic cholecystectomy, that is the point. But what should I know? What you should know is, when the examiner is asking hepatocystic triangle, he is not talking about Callet's triangle. Because if you say Callet's triangle, then it is different. Callet's triangle, you have to use common hepatic duct, you have to use the cystic duct, and you have to use the cystic artery. You have to use the cystic artery. These are the boundaries. And only one content is there, that is lymph node. There's only one content, which is lymph node. This is actual Callet's triangle. So if you really want to talk about Callet's triangle, it is different. It has common hepatic duct, it has the cystic duct, but it has cystic artery as the boundary, not the inferior border of liver, And what are the content? Content is only one, that is the lymph node. So be careful about this. Or some books, what they are doing nowadays, they are telling that let us talk about modified Callet's triangle. If you have used the term modified Callet's triangle, maybe then you can use it for hepatocystic triangle. But anyway, cystic artery is a content of the hepatocystic triangle. So be careful about these things. These are controversial topics. Keep your answer as cystic artery because you're talking about hepatocystic triangle here. Now look at this question. Match the following. And there are ureter, seminal vesicle, ductus deferens, prostate. I have given you paper pattern same as what you get in INI-CET also. NEET PG, INI-CET, they give this kind of questions. So you should practice that way only. So what are we looking at? This is posterior view of the dissected male viscera. If it is the posterior view of dissected male viscera, then how will I identify them? You see the schematic diagram is there, use that. So schematic diagram, yes. You have to understand the structure which you see here, marker D, is the prostate. The structure which you see as marker D is the prostate. This is the prostate. So that is the prostate, yes. You can mark here that we are looking at the prostate gland here. This is the prostate gland, and I'm shading that area that this is the prostate gland. Okay, so what is opening in the prostate gland? You see, if this is the prostate gland, you will have a common ejaculatory duct opening. What is that? Common ejaculatory duct opening. And a common ejaculatory duct means it will have common opening of two things. Yes, what are the two things which are commonly there? You will find that there will be one seminal vesicle. There will be one seminal vesicle which will give semen contribution, and then there will be one ductus deferens or vas deferens. There's a ductus deferens or vas deferens, but look at the relation. Look at the relation. Number one, seminal vesicle will be large and lobulated kind of structure. Seminal vesicle will be large and lobulated kind of structure. Seminal vesicle is large and lobulated kind of structure. Whereas ductus deferens is like a tube. It's a muscular tube. It brings semen, the sperm. So you have marked the seminal vesicle. Where is ductus deferens? This is going to be the ductus deferens. This is going to ductus deferens, means the marker C. Marker C is ductus deferens. So if you're telling that marker C is the ductus deferens, like that, yes, that is the ductus deferens. And then what is marker A, which is coming from here? From the periphery it is coming. You see this one. This one, what is that? That is ureter. Ureter, which is to open into trigone of urinary bladder from the posterior side. That is ureter. So that will be ureter. Yes, you start from here. This is the prostate. Tell this is the seminal vesicle. You can shade the seminal vesicle. So as you are shading the seminal vesicle, you can tell that this is the seminal vesicle. Now you have shaded the seminal vesicle also. Then what about the ductus deferens? As you are talking about ductus deferens, you have to start from here only. Start from here only. Here only. Start from here only. Let us demarcate the ductus deferens. As you are demarcating ductus deferens, you can see that this is the ductus deferens. That is the ductus deferens, which is going like this. Going like this, that is ductus deferens. Now, if that is the ductus deferens you are talking about, if that is the ductus deferens, then where is the ureter? And you can see even ureter. Ureter will be lateral most. Ureter will be lateral most. So if you say ureter is lateral most, can you show it? Yes, that will be ureter. That will be ureter. And ureter doesn't come down. Ureter will just enter here at this level, trigone. So at this level, it will enter. That is the ureter. So ureters will enter. It will be lateral most, first of all. Like you can see, this is the ureter. So ureter is lateral most, and it will enter into a trigone at this level. It doesn't come down there. So maybe you have some idea now. And as you have narrowing of esophagus, which subject to follow, ENT surgery or anatomy? Better anatomy. Better anatomy. For narrowing of esophagus, you just remember that it is 15 centimeter from upper incision, 23 to 25 centimeter from upper incision, 28 centimeter from upper incision, 40 centimeter from upper incision. 15 centimeter is the beginning of the esophagus where you have cricopharyngeal sphincter, and the 23-25 arch of aorta, and 28 centimeter left principal bronchus, and 40 centimeter is that diaphragm opening. Just remember this one. This is enough. So you tell 15 centimeter from upper incision, esophagus has the beginning. It is cricopharyngeal sphincter, narrowing. 23 to 25 centimeter, as per Gray's Anatomy and Sebastian surgery, it is the arch of aorta compressing esophagus posterior. And 28 centimeter left principal bronchus, and 40 centimeter when esophagus passing the diaphragm. These are the four narrowings. 5, 4, 3. 4. Remember 4. 4 is better. So in this, you can just go through some details here. Ureter is thin tube and deep and lateral. It is the lateral most actually. Then it will course medially. And if you say ductus deferens, it is muscular tube and If you say seminal vesicle, it is wider, it is lobulated, and prostate, of course, it will be inferior to bladder. So these are the things which you can use to identify the structure. And we already have identified, so your answer should be 1 is A. Ureter is A. As you can see, this is the ureter. So like that, you can do the matching and try, and choice A will be the perfect match. Now, once you are through that, you are looking at this question, and it is asking about the action of muscle which is attaching to the arrow mark region. Arrow mark region, this area. So that area is basically gluteus maximus. That is the origin of gluteus maximus. Insertion is two places. Insertion 25% fiber into the femur, and then you'll see 75% fiber into the tibia. Into the tibia, I'll show a diagram also by iliotibial tract. It will go there. But what is the action? Is it working on tibia? Cannot say that it is working on tibia, but of course it is working on femur, and it is the chief muscle of hip extension. Now, if you say it is the chief muscle of hip extension, that is gluteus maximus you are talking about. Gluteus maximus supplied by inferior gluteal nerve. So inferior gluteal nerve supplying gluteus maximus for hip extension, but that option is not available. Look at the Gray's anatomy then. It'll say it is also working like a lateral rotator. It is also working like a lateral rotator with the deep muscles which are deep to it, like it work with piriformis. So it'll be working with piriformis as a lateral rotator. And if it is not given, it is not given. In this question, it is not given. Then number 3, you say it is also abductor, especially the upper fibers. It is also abductor. Abductor of, it is all working at hip joint only. So abductor of the hip joint. So that is the answer here. That is the answer. So if you want to find the answer, it is choice number B. But how did you reach the answer? Why not medial rotation? Medial rotation is done by gluteus medius and gluteus minimus, and also tensor fascial lata, and they are supplied by superior gluteal nerve. So there is a superior gluteal nerve supplying 3 muscles. The superior gluteal nerve supplying 3 muscles, gluteus medius, minimus, and tensor fascial lata. That is the one which will do medial rotation of the thigh, not the lateral rotators. This is the lateral rotator muscle, gluteus maximus. So abduction is good. What about knee extension and knee flexion? If you're talking about knee extension, then knee extension is done by quadriceps femoris. Quadriceps femoris chiefly. Though, understand, iliotibial tract help in extension. Iliotibial tract help in extension, but it is too far a thinking. It is quadriceps femoris which work for knee extension. Then what about the knee flexion? Knee flexion, it is hamstring muscles. It is the hamstring muscles which work for knee flexion, not the gluteus maximus. Gluteus maximus, you should focus upon hip joint. So should I keep my answer as abduction? Yeah. Look at this. This is gluteus maximus. Look at the origin. When you look at the origin of gluteus maximus, you have to understand that it is taking origin from the hip bone. It is taking origin from hip bone, the lateral surface, and more posteriorly. Not only that, it is also taking its origin from the sacrum bone, and also coccyx bone, and one ligament which is called as sacrotuberous ligament. So it takes origin from the sacrum bone, it takes origin from the coccyx bone, sacrum and coccyx, and it also takes origin from sacrotuberous ligament. So this is the big origin of gluteus maximus. See the maximus, such a big muscle, it will have big origin. So what is the origin? The hip bone, pelvic bone, ilium part of the hip bone. So it is taking origin from ilium part of the hip bone, and also it is taking origin from the sacrum, as we have seen the diagram, inferolateral aspect of sacrum on the dorsal side, and it is also taking origin from dorsal side of coccyx. It is also taking origin from sacrotuberous ligament. What is the insertion? Insertion, 25% fibers into gluteal tuberosity of the upper posterior femur. So as you will see that this is the insertion. What is the insertion? This is the insertion. Yeah, but what is the insertion? Insertion is gluteal tuberosity. So what is gluteal tuberosity? All of these are repeated questions. I'm again telling you, whatever questions I have taken, they're all repeat topics, high chance of coming again, and you should know everything about few topics. One of the everything about few topics is gluteus maximus. So this is inserting into gluteal tuberosity. Yes. And gluteal tuberosity, where is gluteal tuberosity? Upper posterior femur. So upper posterior femur, you have gluteal tuberosity. Yes. How much of percent? 5 or 25%. So where is 75%? 75% in the Gerdy's tubercle. So how it goes into Gerdy's tubercle, which is anterior aspect of the medial condyle of tibia. Anterior aspect of the medial condyle of tibia, the Gerdy's tubercle, that is where it is inserted. Now this iliotibial tract is insertion of two muscles, not only gluteus maximus, but also tensor fasciae lata. So even the tensor fasciae lata coming from hip bone and gluteus maximus coming from hip bone, they both insert on the anterior tibia, medial condyle, Gerdy's tubercle. What is the function? Function is just to stabilize the knee joint. It can help in knee extension. Can help in knee extension because obviously anything which crosses anteriorly, it can pull the tibia anterior. And if you pull the tibia anterior, knee extension. So of course it can pull the tibia anterior. And when you pull the tibia anterior, you are working with quadriceps femoris, which do knee extension. So it can help in knee extension, of course, but that should not be your first answer, that it is doing knee extension. First answer should be mostly about the hip joint. First thing is it can pull the femur posterior. Pull the femur posterior means the hip extension. It can also rotate the femur laterally. Rotate the femur laterally means lateral rotation hip joint. And then it can also pull the femur like this, abduction. So it has three functions. Pull the femur posterior, hip extension. It can rotate the femur like this, lateral rotation. It can pull the femur like this, abduction. That is three actions of the gluteus maximus. Then you can say it can also do knee extension via iliotibial tract. So here, as you can see in this table, we are mentioning hip joint extension, lateral rotation, and abduction if you're talking about upper fibers. That is the action of gluteus maximus. What about the knee joint? Knee joint stabilization, the first thing you should say stabilization, and terminal extension. It can help in terminal extension, as I mentioned, but don't talk about this too much because it is too much of information. Now once you have this information, you can very well choose your answer as abduction, because first action should be hip extension, not given. Second action should be lateral rotation, not given. It is also at the hip joint. So you have chosen the third action, which is abduction of thigh. Read Gray's Anatomy, you'll find the details. We are talking about gluteus maximus here. Now, as you proceed further, again, a simple question for people who have their basics intact. So which of the following muscles supplied by superficial peroneal nerve? You know, there's a common peroneal nerve. It'll give two branches. There'll be superficial peroneal nerve. There'll be deep peroneal nerve. Deep peroneal nerve, also called anterior tibial nerve. And it'll go to the anterior tibia. In the anterior tibia, you will have the extensor tom, dick, and hairy. Extensor tom, dick, and hairy means the tom is tibialis anterior. Dick is the extensor digitorum longus. Hairy is the extensor hallucis longus. But it supplies one more muscle, which is peroneus tertius. Peroneus tertius. So there are four muscles supplied by this nerve. I'll tell again. This is common peroneal nerve. It gives two branches. That is why it's called common. It'll give a superficial and deep branch. The superficial branch is superficial peroneal nerve. Deep branch is deep peroneal nerve or anterior tibial nerve. So deep peroneal nerve, anterior tibial nerve, what does it do? Go anterior to tibia. And going anterior to tibia, what will do? Supply the anterior extensor compartment. What is there in the anterior extensor compartment? Extensor tom, dick, and hairy. Who is this extensor tom, dick, and hairy? The tibialis anterior and extensor digitorum longus and extensor hallucis longus. So what are they doing? They are extending the toes, extending the ankle, dorsiflexion, you can say. If you damage this nerve, then there will be foot drop. The patient will have foot drop, cannot do dorsiflexion at the ankle. Ankle and toe dorsiflexion is gone. They'll walk with the high steppage gait. High steppage gait. They have to clear the foot from the ground. So walking with high steppage gait. Already these are all questions. Then what about superficial peroneal nerve? Superficial peroneal nerve is going to the lateral leg. It'll supply muscles in the lateral leg. There are only two muscles in the lateral leg. Peroneus longus, peroneus brevis. And they turn the sole lateral. If you turn the sole lateral, means foot eversion. They do the foot eversion at the subtalar joint. Subtalar joint. And you got your answer. You got your answer because question is asking superficial peroneal nerve. So superficial peroneal nerve is the nerve of lateral leg. In the lateral leg, it will supply lateral leg muscles. Peroneus longus, peroneus brevis. That is your answer. They turn the sole lateral, which is foot eversion at the subtalar joint. Everything is a question. When I do one question, I am taking care of 10 more questions. That is how it should be actually. A teacher should teach in such a way that when you are taking care of one question, you should be taking care of 10 questions in entirety, at least 5 questions. And you see, maybe you have done 20 questions, but in fact, you have done 100 MCQs by this time. And I can challenge anybody. Anybody can challenge me that show me those 100 MCQs which you have done. I'm talking about last 15-year questions. In last 15-year questions, I have taken care of 100 questions by this time. You challenge me, I'll give you the proof. Because that is how I teach, and that is how confident I am about my skill. This is my skill. I have developed this skill in last 24 hours. Not 24 hours. 24 hours with this paper, 24 years. So you are trying to say that perennius longus and brevis is the answer? Yes. That means choice number A is the answer? Yes. What about perennius tertius? Perennius tertius is anterior leg muscle. Perennius tertius is anterior leg muscle. You can see perennius tertius is anterior leg muscle. So perennius tertius will be supplied by anterior tibial nerve, which is called as deep perennial nerve. What about extensor hallucis? Extensor hallucis you have just seen. Extensor hallucis longus is the muscle which is in the anterior leg. It is Tom, Dick and Harry, the extensor Harry. So this is the extensor Harry, and that is to be supplied by, again, deep perennial nerve, not the superficial perennial nerve. So that is how. You can see the diagrammatic form also. In this diagram, you can see turn the sole lateral is foot eversion done by 2 muscles. There are 3 muscles basically working, but perennius longus brevis and perennius tertius. Even perennius tertius can help for foot eversion at subtalar joint. Otherwise, you are doing dorsiflexion of the foot, which is called extension, and for that you have anterior tibial nerve. So you see here, this is the sciatic nerve you are following, and as you follow the sciatic nerve, it will give 2 branches, common peroneal nerve and the tibial nerve. We are not following tibial nerve, which will be posterior tibial nerve going posterior tibia and in the calf region. So that is what we are following. We are following common peroneal nerve. It is called common because it divides into 2. Divides into 2, you can show here that what 2 division it is giving. You see, this is the common peroneal nerve, and common peroneal nerve is going lateral to the neck of fibula. As it goes lateral to the neck of fibula, it can be damaged here, and it can be leading to foot drop and loss of foot eversion, some sensory loss also on the dorsum of the foot. So it is giving one branch, which is, now you can follow, going anterior to tibia. So it is called as the deep peroneal nerve or deep fibular nerve or anterior tibial nerve. It is the same. So if that is the anterior tibial nerve or deep peroneal nerve, what about the other? Other you can follow, and this is the superficial peroneal nerve. And superficial peroneal nerve, as you are following, you will see that it is going to supply 2 muscles and skin on the most of the dorsum of the foot. So as you follow superficial peroneal nerve, what are the 2 muscles it is supplying? Peroneus longus and peroneus brevis, and then it will supply skin, most of the skin on the dorsum of the foot. Okay, what about the deep fibular nerve? As you are following the deep fibular nerve or deep peroneal nerve, it is supplying tibialis anterior. Anterior Tom, Dick and Harry. The Tom is tibialis anterior. Who is the Dick? The digitorum, extensor digitorum. And who is the Harry? Harry is extensor Harry, extensor hallucis. And one more, that is the peroneus tertius. So remember, peroneus tertius or fibular tertius is supplied by anterior tibial nerve. The first muscle is tibialis anterior. Second is extensor. Third is extensor hallucis. And fourth is peroneus tertius, all supplied by the deep peroneal nerve, which is also called anterior tibial nerve. I have discussed. Otherwise, this 1 and 2 to be supplied by superficial peroneal nerve. Also remember that the dorsum of the first web space, which is L5 dermatome, is supplied by deep peroneal nerve. Otherwise, most of the skin on the dorsum of the foot is supplied by superficial peroneal nerve. You can extend it here, and as you extend it here, you'll find that superficial peroneal nerve is supplying skin, most of the skin on the dorsum of the foot, except the first interdigital space, because first interdigital space, as we have mentioned, will be supplied by deep peroneal nerve. Then what about the little toe and lateral margin? If you look at the little toe and lateral margin, you will see that the little toe and lateral margin is to be supplied by sural nerve. That is sural nerve. What about the medial dorsum of the foot? Medial dorsum of the foot. If you look at the medial dorsum of the foot, there will be a nerve here, and there will be saphenous nerve actually. Saphenous nerve will also supply. So basically, when you look at the dorsum of the foot, there are 4 nerves, sensory supply. Medial dorsum of the foot is saphenous nerve. The little toe lateral is the sural nerve branch of tibial nerve. If you say first interdigital space, that is the deep peroneal nerve. Otherwise, most of the dorsum of the foot is supplied by superficial peroneal nerve. The major nerve is superficial peroneal nerve on the skin on the dorsum of the foot. So with that, you can keep your answer as choice number A, because it is peroneus longus and peroneus brevis, and that is all I wanted to take care of. Normally, I get the complaints that you don't finish in time. So let me see, 9:20. We started at 7. We got delayed 7:15. So 9:15, 2 hours. I have tried to finish within 2 hours. That is some achievement, because normally I will take more than that. But I went very fast, and that could be a problem for the students. They cannot follow as I go that fast. But you can revise this again, means you can repeat view. So thank you very much, Grace, for giving the opportunity for me to serve you. We have only one purpose, don't forget. Our purpose is, yes, that you should become a better human, better doctor, skillful doctor, knowledgeable doctor, so that patient who come to you with a depressed face should go back by having a smiling face. That's the only purpose. I have only one purpose, that you should become a great skillful doctor. If you're asking about PDF, I'll have to communicate with the team who is working. PDF, this is 2020. I have no problem in giving the PDF, but that PDF has to go through a channel, and that channel, why my head is getting in the video, the head is gone, means the scalp. I think the team has put some cropping. That cropping, yeah, now it is fine. It should come now. So PDF, I have no issue. I'll give it to the team. I'll request the team to put it on the YouTube if possible. Yes, Dr. Ambika, thank you very much. And all the best, Indu. Take care. And may God bless you with all the happiness. And the first happiness is when you get successful in getting your good merit rank. Okay, take care. Bye-bye. God bless.
Thank you, sir.